So there we go. I'd like to say as well, following on from Christian, hello, very much welcome to today's spring tutorial from the British Association for Cytopathology, the BAC. My name is Tony Maddox. I'm the chair of the BAC. So we have an exciting programme today which covers important areas of diagnostic cytopathology, and it should be of particular interest to pathology trainees of all grades, but particularly those coming up to their exams, and also of interest to biomedical scientists studying in the UK and elsewhere, studying in the UK for things like diploma of expert practice in diagnostic cytopathology, advanced specialist diploma, and those kind of exams. I should just say that there was in the original programme, which was going to be face-to-face, which we had to change because of train strikes, but there was going to be a cervical cytology element, and I would say for those of you that are also interested in that, that is being rescheduled as a face-to-face event in the UK. So there'll be details about that in the next few days or weeks. So that's the welcome done. I'd like now to introduce Dr. Maria Buttice. She's a consultant cytopathologist and also a GI histopathologist. We're currently a consultant, I think, for a couple of years, working at Guy's and St Thomas's Hospital in London. She graduated from University College London and did her postgraduate medical training here in London, and was a trainee at St Thomas's, and there developed a keen interest in cytology at a very early phase, because St Thomas's, as many of you will know, is a centre of excellence where cytology is leading in patient care. They have many fine needle aspiration clinics. They've done rapid on-site evaluation for many years, both performed by pathologists and by biomedical scientists. And Maria has given many poster presentations, written many articles for the BAC and for various journals. She's actively involved in cytology teaching and teaches on a number of courses, and she's very keen to encourage trainees to develop the same interest that she has in cytopathology. She's a member of the British Association for Cytopathology, which I'm very grateful for. And she hopes to expand her cytology repertoire, continuing teaching further than that. And she would also like me to say that she's had the privilege of being trained by Dr. Ashish Chandra, who is a world-renowned cytopathologist, and I believe may also be on our panel. Oh, look, there he is. And she has inspired her interest in this specialty, and we're all, to be straightforward about it, we're all very lucky to have Ash as a colleague, actually, in truth, so I would entirely second that. Anyway, so I'll stop gibbering. I'll hand over to Dr. Buttice now, and she's going to talk about pancreatobiliary cytopathology, diagnostic approach, reporting terminology, and just to reiterate from what Christian said, put your questions in chat and then we'll deal with those at the end of the talk. So I'll hand over to Dr. Buttice now. Thank you very much.
Thank you so much for that introduction. Thank you. I'm now just going to share my screen so I'm able to project my presentation. So I hope that's nicely projected there. So thank you all. It's a great privilege to have been invited to the BAC tutorial. So my name is Dr. Maria Buttice, and I'm a consultant cytopathologist at Guy's and St Thomas's. My topic today has been that of pancreatobiliary cytology, and often this is one of the fields that's quite challenging to cytopathologists, in that we are often rendered to make precise diagnosis, and often it is the only modality by which pancreatobiliary lesions are sampled. So I hope that by the end of this session, I'm able to give you a practical workup approach to these lesions. I would also like to take the opportunity to talk about the new standardized terminology for reporting of pancreatobiliary cytology. So as we are probably aware, there's a Papaniculi classification, and now we have the new WHO classification, which essentially aligns itself with the histology of the digestive tract WHO classification. So I will briefly touch on the new classification and how it differs from our Papaniculi classification. So pancreatobiliary pathology, and mostly neoplasia, affects millions of people worldwide, and it's estimated that each year nearly 500,000 of people are diagnosed with pancreatic cancer. Now, our understanding of pancreatobiliary pathology has increased tremendously over the last 20 years, and that's probably due to a multifactorial reasons, more large multi-institutional studies, extensive molecular analysis, which has completely revolutionized the way that we treat diseases to the cellular level. In addition, we've had advances in imaging techniques, and that has facilitated and improved our identification and characterizations of pancreatobiliary lesions. And as a result, our cytopathology diagnosis has become more vast and precise. This altogether has resulted in more treatment options for patients, which have ultimately resulted in better outcomes. In terms of the workup to the diagnosis of pancreatobiliary lesions, so this is probably one of the most important fields where actually a multidisciplinary team approach is fundamental and to the core of being able to provide an accurate and concise diagnosis. And often as cytopathologists, we rely heavily also on imaging modalities and what's been seen on imaging, as well as ancillary testing, which I will go through in detail later on in the talk. But essentially, before my day-to-day reporting of pancreatobiliary lesions, so before I start reporting, I'd like to know a bit about the clinical background, so more about the patient's age, sex, social factors if those are available, any family history of malignancy or familial syndrome such as von Hippel-Lindau syndrome or MEN, which will predispose these patients to certain pancreatic tumours. Then also clinical symptoms. So how has the patient presented? Has the patient presented with abdominal pain, obstructive jaundice, correlated with tumour markers? And one of the tumour markers which is commonly measured in pancreatic lesions is CA19.9. I also like to look at the imaging. So what is seen on imaging? So firstly, is the lesion solid? Is it cystic? Is it mixed? And where is it located? Is it in the biliary tract or it is in the pancreas? And if it's in the pancreas, where? Is it in the head of pancreas? Because that can give you a differential, or is it in the body and tail? And then before I've had all that information, I now go into the cytology and I'm able to assess, considering all the clinical and imaging information that's been provided. The other thing to bear in mind is that because of the cytology, we're also at the advantage that we've got extra material which we can send off for ancillary testing. So for example, in the case of cystic lesions, the fundamental biochemical markers that will help us distinguish the cystic lesions are fluid CEA levels, and I'll go into explain why, and also the amylase. And then more recently, we've had advances in molecular, which allows us to identify certain molecular alterations which are associated in the neoplasia pathway. So the role of cytology, as I've said, is fundamental in investigating pancreatic lesions, and mainly so because the pancreas is a deeply situated retroperitoneal organ, and that often makes sampling of these lesions quite difficult and associated with significant patient morbidity. So currently, ERCP and EUSs currently afford the two easiest methods for sampling of such lesions, and they often only provide the only modality of diagnostic information. So as cytopathologists, we are called to render meaningful diagnosis with as much precision as possible. So both ERCP and EUSs can gather samples either through brushings, so most commonly in the biliary tract, we can perform brushings, and then if there's a target lesion, we can perform fine needle aspiration. And both of these samples can garner other small tissue fragments, which can be used to make cell block and ancillary testing. So here I've got a diagram taken from the WHO classification, which shows how we can triage our cases. So we have, for example, pancreatic cyst fluid. Now, often with the cytospins, our cytology will often show features in keeping with cyst fluids, such as hemosiderin-laden macrophages, bloods, and sort of amorphous debris. And often these are paucicellular. So in isolation, they are often inadequate or insufficient to make a precise diagnosis, okay? But it is the addition of other ancillary testings. So for example, the biochemical markers, CEA and amylase, in addition to some molecular analysis that will allow you in conjunction to be able to make a diagnosis of the nature of the cyst. And there's a flow chart which I can go through in a bit more detail later. With regards to solid lesions and biliary brushings, so in terms of triaging of cases, so at St. Thomas's, we have the privilege of being able to perform rapid on-site assessments. And what that allows us to do is mainly two things. The first one is to ensure that we have enough diagnostic material while the patient is having the procedure. So if they don't have enough diagnostic material, we can ask for more material to be provided. And then secondly, it allows us to triage the case accordingly. So for example, in the case of a solid lesion, we'll often have air-dried direct smears and then alcohol-fixed direct smears. And if we have lesional material, we can then ask for needle washings to perform a cell block and immunohistochemistry depending on what the lesion is. So for example, in the case of a neuroendocrine tumor, we'd require a cell block to confirm it by immunohistochemistry. Then with biliary brushings, there are mainly two modalities of how we can prepare the brushings. So the first one is by performing direct spreads. And what this allows, it allows you to assess the pattern of the material on the direct spreads, okay? But the disadvantage is that we don't have any additional material to perform cell block immunohistochemistry and molecular if that is required. So the alternative would be to place the brush directly into preservative solutions, which then allows you to essentially perform a liquid-based cytology such as a thin prep. And this has the advantage of offering better cellular preservation and also less mechanical artifact as a result of direct spread in the material. And then you've also got cell block and immunohistochemistry if you need to perform further tests. This flowchart nicely shows, as I've said, the importance of correlating clinically and also radiologically before we assess a pancreatic cytology specimen. And essentially, for simplistic purposes, I divide pancreatic lesions into three main types. The first type is the solid lesion, and your solid lesion commonly can be divided into ductal, which is by far the most commonest, and non-ductal lesions. And your ductal lesions are often adenocarcinomas or inflammatory conditions such as pancreatitis. Examples of non-ductal tumours include neuroendocrine tumours, which are the most commonest of the type, but yet variably infrequent in comparison to your ductal adenocarcinomas. And then you can have solid pseudopapillary tumours and acinar cell carcinomas and various other rare tumours. In terms of your solid and cystic components, so these can arise in two settings. So it can arise as a result of solid tumours undergoing cystic degeneration, or it can arise in the setting of a cystic lesion, which has solid areas. And often imaging modalities will help you distinguish those because they'll be able to see solid components in a cyst. So when we go on to look at cystic lesions, the two main clinical questions that directs the management of patients in cystic lesions is whether the tumour is mucinous or non-mucinous, okay? And then once you distinguish the category, you then need to know whether the cyst is low risk or high risk for malignancy. And this requires a culmination of cytology and molecular and imaging. So essentially, with mucinous cysts, the most important biochemical marker is CEA, as this is quite specific, and actually elevated levels of CEA with a normal amylase favors a mucinous etiology of a cyst, okay? Contrary, if you have elevated amylase and near normal CEA, that favors a non-mucinous cyst, such as a pseudocyst. The other important thing to consider now is the molecular, which has also aided the stratifications of cysts. And I've got a table in the next slide, which essentially shows A single KRAS mutation often supports a neoplastic mucinous cyst. Okay, and then if you have the addition of a GNASH mutation, that supports intraductal papillary mucinous neoplasm. And it's important to remember that with IPMNs, you'll be able to see it on imaging as it's arising from a main duct or a branch duct. So that's in corroboration with imaging features. So the addition of those two mutations would favor an IPMN. It's important to also consider that obviously with the molecular, we are using it as an adjunct to our cytological assessment. So it's not taken in isolation, and it's actually the combination of all the features that allows you to give a precise diagnosis. Okay, the other thing I wanted to show you is that we have various other mutations such as TP53 and SMAD4, which is a tumor suppressor gene, and that's often lost in up to 55% of malignancies. And these genetic alterations are often found in late in the adenoma to carcinoma progression pathway. So if you have these mutations, they are suspicious for high risk or high cytology and advanced neoplasia. And obviously this would be reflected in what we see in our cytology preparations. So this is a rather large table, but just to show you how large of an immunohistochemistry panel is now available for the assessment of pancreatic lesions. And essentially they are available. They should be used in adjunct to our cytology initial assessment, correlating it with clinical. But essentially, as an example, as I said, SMAD4 is a tumor suppressor gene, which is available as FISH, but also you can perform it in immunohistochemistry. And the loss of nucleus staining is highly suggestive of adenocarcinoma, given the cytomorphology. So the WHO reporting system for pancreatobiliary cytopathology. So the reporting system essentially provides a framework that can be used for pathologists that are consistently categorized, and it allows us to create reports that are clear and consistent and provide underlying diagnostic information which can be uniformly understood by pathologists and clinicians all around the world. The new WHO reporting system for pancreatobiliary pathology is a revision of the Papua-Nicolau Society, and essentially aligns itself to the histology WHO classification. And I'll explain the few differences of the new classification. So for those who are well aware of the Papua-Nicolau classification, so the Papua-Nicolau classification uses a 6-tier system. Okay, so we have non-diagnostic, negative, atypical, neoplastic benign, neoplastic other, suspicious, and positive for malignancy. And the main difference between the Papua-Nicolau Society classification and the new WHO classification evolves around the neoplastic other category. So in the Papua-Nicolau classification, the neoplastic other actually encompasses a wide spectrum of low-grade malignant tumours, including neuroendocrine tumours and solid pseudopapillary tumours. Now, those two tumours have been removed from the neoplastic other category and placed under the malignant category to align itself with the histology reporting. So it's a mirror image of our histology reporting digestive WHO classification. And then the neoplastic other is further subclassified into pancreatobiliary neoplasm low risk and pancreatobiliary neoplasm high risk. And essentially you can divide those two on cytomorphology grade. And I'll go through the way that we do that. So just to summarize, we now in the WHO reporting system have 7 categories. So number 1, insufficient, inadequate, or non-diagnostic is exactly the same as the Papua-Nicolau classification. R2, benign or negative for malignancy. That includes non-neoplastic lesions, benign lesions, and neoplastic benign lesions such as serous cystadenoma, and I will show you some examples of these. Then you have the atypical category, which again is the same as the Papua-Nicolau, and then 4 and 5 category is the neoplastic other, which was in the papaniculi and now has been subdivided into low risk grade and high risk grade. And these are often intraductal or intraepithelial neoplasia and mucinous cysts, which we can stratify into low risk, high risk, depending on the degree of cytological atopia that is seen. Then we have the suspicious for malignancy category, and then finally the malignant. So what I would like to do just briefly is just to explain that the diagnostic category, through lots of meta-analysis and studies, are associated with an estimated risk of malignancy, and that ultimately determines how we manage patients. So for example, in an atypical category, 30 to 40% risk of malignancy, essentially the patient would need a repeat FNAB. If you have a benign category, you correlate clinically, and often there is no requirement to treat the patient, and actually follow-up is all that's required. This is the same for the risk of malignancy of bile duct brushings. So where you call a bile duct brushing malignant, as you can see, your estimated risk of malignancy is as high as 96 to 100%. And essentially by calling a biliary brushing malignant, the patient will then be treated according to the stage. So if the tumor is resectable, the patient will undergo a resection. What I would like to do is, before I go through all the diagnostic categories, I would like to show you a few nice images of what benign pancreatic tissue looks like, because often with our cytology preparations, we'll often have and see benign pancreatic tissue. So by and large, pancreatic parenchyma is comprised of exocrine acinar cells, which we see beautifully illustrated here, and ducts. And often they're admixed and have scant connective tissue. The other component is the endocrine component, known as the islet cells of Langerhans, which are often embedded throughout the body and tail. So what we can see here are these benign grape-like clusters of acinar cells, and they are singly dispersed, but also in nice grape-like clusters. Moving on to higher power, we can see that they are uniform epithelial cells. They often have abundant granular cytoplasm, eccentric nuclei, fine chromatin, and often have a single small nucleolus. What we can see here are the benign pancreatic ductal epithelial cells, and you can see that they're often described as having a honeycomb sheet or a lattice arrangement, and you can see that they're all uniform. The cells are all respecting each other's neighbors. They have round to oval nuclei and inconspicuous nucleoli. So often, depending on the cellularity, you'd expect to see varying amounts of normal pancreatic tissue. The other thing to consider are contaminants that we may encounter during our cytological assessments, and these are predominantly related to where the lesion is and how it's been sampled. So for example, with pancreatic head lesions, often a transduodenal approach, EUS, is performed. So you'd expect to see varying amounts of benign duodenal epithelium. And this is a picture to show what it would look like in our cytology preparation. So you can see that you have evenly arranged epithelial cells, and often you have cleared cytoplasm as a result of the goblet cells. If you have a lesion in the body and the tail of the pancreas, you'll often have some gastric contaminants, and these are beautifully identified by the apical cups of mucins that are seen. Other contaminants can include mesothelial cells, hepatocytes, and kidneys. So it's important to consider that when you're assessing a cytology preparation, look for your benign components, so your ductal and acinar cells, and also any other contaminants. So what I'd like to do now is I'd just like to briefly go on to talk about each diagnostic category and give you some examples. So in terms of using an insufficient, inadequate, or non-diagnostic, now these terms can be used interchangeably. And essentially, what you're saying is that you're unable to make a precise diagnosis, and this can be due to either qualitative reasons or quantitative reasons. And I've here put down at the bottom of the slides reasons that would render a sample insufficient. So for example, if it's heavily blood stained or you've got lots of contaminants that are obscuring the cellular material, you wouldn't be able to make a diagnosis. If you've got preparation artifacts such as air drying artifact that doesn't allow you to assess the cell cytology morphology, then you would call it inadequate. The other situation where you would call something inadequate or non-diagnostic is when they've told you that they've sampled from an actual solid or cystic mass and all you have is normal pancreatic acinyl ductal cells. So essentially you're calling it non-diagnostic because what you're seeing does not explain the radiological appearance of a mass lesion. So here I've put an example of a highly blood-stained sample with macrophages, which is inadequate for diagnosis. Here are some of the common benign non-neoplastic processes which we can often encounter in cytology, and then the benign neoplastic processes. And I'd like to go through a few of these just to show you a few of the key features that you'd expect to see on cytology. So in the case of acute pancreatitis, so often you'll be guided by the clinical history. So the patient will have elevated amylase and will have deranged LFTs and may present acutely with right upper quadrant pain. Now, we can see these ductal epithelial cells and they're often infiltrated by numerous neutrophil polymorphs. Important to consider that these may show some mild anisonucleosis, but is as a result of the injury of the epithelial cells to the acute inflammatory cells. And the background will include inflammatory cells, and you shouldn't see coagulative necrosis in these cases. Similarly, cholangitis. So if you have inflammation of the biliary tract, you'd expect to see similar sort of changes as that in acute pancreatitis. So again, an inflammatory background and epithelial cells that are infiltrated with acute inflammatory cells. And often you will see some bile pigment in the background, which is highlighted by this green acellular material. Chronic pancreatitis is often seen in the case of several bouts of pancreatitis and can be associated with alcohol excess. And often these can be cellular material, and in the background you have lots of lymphocytes and plasma cells. Autoimmune pancreatitis is something that's been of great talk in the last few years as a result of our recognition of IgG4 disease. And essentially what I'd like to mention is that on its own with cytology, we're unable to call it IgG4 disease, but we can raise the clinical suspicion of it. And it actually requires a culmination of IgG4 ratios, histology, and also serum IgG4 that allows us to make that diagnosis. But essentially on cytology, what one would see is these stromal tissue fragments and also a dense inflammatory cell infiltrating the background of an excess of plasma cells. Lymphoepithelial cyst, as the name describes, is essentially a squamous line cyst, and on cytology we see this amorphous granular debris which almost resembles sort of cracked thick colloid with the cracked artifact, and you'd see keratinous debris and lots of anucleated squamous cells. These often on imaging can be confused with a neuroendocrine tumour, so being able to provide that diagnosis cytologically is very important. They're benign and they don't require resection, so by making that diagnosis the patient can be discharged. Our pseudocysts here, so these are approximately constitute 75% of all pancreatic masses. And when you aspirate this pseudocyst, essentially you get cyst contents, including macrophages and amorphous granular debris. And as I said at the beginning, the most important measurement for pseudocysts is amylase. And often amylase will be elevated and will have low CEA levels. So with a imaging of a cyst with a high amylase and a low CEA and cytology confirming cyst contents, you can confidently ascribe this to a pseudocyst. And often molecular alterations are absent and not required to make the diagnosis. Moving on to the benign neoplastic lesions. So Serous cyst adenomas, so these are benign, non-mucinous epithelial neoplasms, and they're often found in females, 2/3 of cases in females, and these are the tumours that can be associated with von Hippel-Lindau syndrome. So often they have molecular alterations in the VHL gene. So essentially, on imaging, the classic feature is that they have a central stellate scar. So on imaging, it will be highly suspicious of a serous cyst adenoma. And what we can see on cytology here are these beautiful, bland cuboidal epithelial cells surrounded by numerous hemosiderin-laden macrophages. And then the other diagram just shows how it correlates to on histology. These will not have elevated CEAs or amylase, so they will exclude a mucinous cyst. So when we move on to the atypical category, so this is essentially an indeterminate category, and it's characterized by cells that have a spectrum of architectural or cellular atypia that can't be ascribed to a benign category or malignancy. But by and large, it favors a reactive process rather than a neoplastic process. These are the sort of cytological features that if you were to see on direct spreads or biliary brushings would give an indication of it being atypical. So you may see a loss of architectural polarity. So your nuclei aren't basally aligned. There might be a mild degree of nuclear crowding. So in the pictures where I showed you that the cells are uniformly spread, they're each respecting each other's boundaries, there might be a mild degree of nuclear overlap, crowding and overlapping. So you might have near to normal NC ratio, slightly nuclear membrane irregularity, and there might be some minor nuclear anisonucleosis to the degree of 2:1, but it shouldn't be higher than that. And your background is often clean and there's no necrosis. So what I'd like to show you is a few pictures of what we would call atypical. So can you see here, we've got, I hope you can see my arrows. So you still do have this sheet arrangement, but there seems to be some sort of disorganization to the architecture. You don't have the honeycombing or lattice in the way that you can't draw around each cell. And here we have some mild nuclear overlapping, and there are some nuclear irregularities. Can you see here we've got oval shaped nuclei and more round shaped nuclei, but our background does not contain either inflammatory cells or necrosis. The chromatin is not coarse and there aren't prominent nucleoli. So in the case of an atypical category, the patient would require a repeat biliary brushing or FMB. So the pancreatobiliary neoplasm low risk. So essentially this includes intraductal or cystic neoplasms with low-grade epithelial atypia. So as I've said, the neoplastic other in the Papanicolai classification has now been stratified into pancreatobiliary neoplasm low risk and pancreatobiliary neoplasm high risk. And your neuroendocrine tumours and solid pseudopapillary tumours are now in the malignant category. And this is to align itself with the histology WHO reporting. So these are some examples of what would be put into the pancreatobiliary neoplasm low risk. So as you can see, pancreatic intraepithelial neoplasia and biliary intraepithelial neoplasia. Now, by default, these two entities will not be seen on imaging because they are not mass forming. And then you have the intraductal papillary mucinous neoplasm, which you would be able to tell on imaging, and then more of the rarer intraductal papillary neoplasm of the bile duct, and then our mucinous cystic neoplasm, which I've described earlier, which can be divided into low grade or high grade, depending on their cytology atypia and also the molecular aberrations that arise in these cysts. In terms of the high risk grade, these are essentially the same as what we see in the low risk grade, so this, but they have high grade cytology atypia. So things that would give you high cytology atypia would include a higher NC ratio. They might have indistinct cell borders. There might be variation in nuclear size within the group of the epithelial cells, but this shouldn't be seen across the whole spectrum of the sample. And usually the background is clean, there's no significant necrosis. Moving on to our suspicious for malignancy category. So this category is essentially reminiscent of a malignant process. However, the features of malignancy are not seen across all the material that we are assessing on cytology. So they may be present in a few of the cell groups, or all our malignant features are not present in their entirety, and I'll go through those features. So as you can see here, when you have well-differentiated adenocarcinoma, they can often actually be bland and difficult to diagnose as malignant, especially if you don't see them in large quantities. But you can actually see that they lack that regular architecture that's seen in normal ductal epithelial cells. And there is nuclear irregularity and variation in nuclear size. So I've put here at the bottom what is required for a malignant category classification. And essentially one of the most important ones is that within the ductal epithelial cells, one expects to see a degree of nuclear enlargement of 4:1. So within that group, I would identify the largest nucleus and then the smallest, and see whether the largest nucleus fits into the smallest nucleus about 4 times. And if it does, and you see that across the spectrum of your cytology preparation, given the clinical history of a mass lesion with background necrosis, coarse chromatin, prominent nucleoli, you could be confident that this is a malignant process. So as I've said, the majority of primary pancreatic malignant neoplasms are often pancreatic ductal adenocarcinomas. And then the cholangiocarcinomas arising from the distal common bile duct can present as masses because of the extension into the pancreas and duodenum. And essentially, they're indistinguishable. So it'll all depend on imaging. What we see on cytology are malignant features. So these are specific lesions that would, if encountered in cytology, we would ascribe it the malignant category as per the WHO classification. And I'd like to show you just a few examples of these tumours. So the features of cholangiocarcinoma, again, are the same as pancreatic adenocarcinoma. We can see that we have this loss of honeycomb pattern, and often referred to as a drunken honeycomb. So can you see here that it's sort of disintegrated and you don't have that beautiful flat sheet which maintains polarity. You can often have 3D dimensional clusters. They're often cellular samples. And again, if they're not cellular samples, you would be looking more at the suspicious category. There is marked nuclear pleomorphism and anisonucleosis. So as I said, within the group, you can identify the smallest nucleus of the epithelial cells and then go for the largest, and then just eyeball to see how many times that nucleus would fit into the small one. And if it's around 4:1, then it is a high indication that this is a malignant process. You can often find atypical single cells also scattered in the background. And as we can see here, we've got this malignant category, and then we can see this benign. So often this is a very good clue to compare your cells of interest to the normal background epithelial cells. You can get background necrosis or dirty material as seen here, and there may be chromatin clumping and prominent nucleoli. So these are similar features as that seen in pancreatic adenocarcinoma. As we can see in these images here, the nuclei are hyperchromatic, irregular. We can see variation in nuclear size to 4:1 ratio and prominent nucleoli. You can often find atypical mitotic figures also. I'd like to just show you an example of a neuroendocrine tumours, because these may often be incidental findings as a result of a patient being investigated for other reasons, and then they find a PET positive lesion in the body or tail of the pancreas, which undergoes FNAB. So what we can see here are the same features as what you would see in a neuroendocrine tumour in other organs. So you can have a monotonous populations of cells. You can see they can have loose aggregates or they can be singly dispersed. and they often have monotonous nuclei, inconspicuous nucleoli, and stippled chromatin. And you would, with the ancillary material, you would perform a cell block and immunohistochemistry to confirm neuroendocrine in nature. Also important to bear in mind that these can be associated with familial conditions such as MEN, and it's important that if the patient is young, you raise the possibility of it being a genetic condition. Neuroendocrine carcinoma, again, similarly to high-grade neuroendocrine carcinoma seen elsewhere, will have similar features cytomorphologically. So often with small cell, you have these clusters of cells which have scant cytoplasm, display nuclear molding, have high apoptotic bodies as a result of high cell turnover and nuclear streaking. And large cell, which is shown here at the bottom, again, is a high-grade malignancy with anisonucleosis and common necrosis in the background. And it's important to make this diagnosis because often they're associated with an invariably poor prognosis. This is an example of a solid pseudopapillary neoplasm. Again, they're not very common, but essentially, if you see them on cytology, they have a distinct cytomorphological features. And these include, on the far bottom here, we've got this beautiful papillary folds with fibrovascular cores. And you can often see these monotonous cells, which often also present in the background loosely. And they often have slender cytoplasm, as we can see here, sort of cometails. And they'll often have vacuolated cytoplasm. The nuclei tend to be round to oval, and they have smooth nuclear membranes. They might have prominent nucleoli. And here the importance is that you can perform molecular, and these often have alterations in the CT-NMB1 beta-catenin pathways. And that, alongside the cytomorphology and also imaging, allows you to make a diagnosis of a solid pseudopapillary neoplasm. Finishing off with acinar cell carcinoma. So again, this is a rare non-ductal malignant tumor of the pancreas, but essentially what we see here is a predominance of an acinar neoplastic process, and it's neoplastic in that it's very monotonous. So you're just seeing acinar cells, which are highly atypical, so different to what our normal acinar cells look like. We can see that we have cellular smears, they are highly cohesive, and they display a lot more nucleatypia than the normal acinar cells, with prominent nucleoli, variation in nuclear size, and there can actually be a granular background. These again will often be seen on imaging. So to conclude, cytology provides a fundamental diagnostic tool for pancreatobiliary disease, and the advances of cytology and imaging and molecular has allowed us to have ancillary investigations that allows us to characterize cystic lesions, essentially using biochemical markers with CEA and amylase, and then also molecular tests such as KRAS, GNASH mutations, SMAD4. And now the new WHO reporting system aligns itself to the histology reporting classification of pancreatic lesions, and we should be implementing this in our cytology reporting of biliary lesions. So thank you so much for listening. I'm happy to take any questions now.
Okay, Maria, thank you very much for that excellent presentation. Well illustrated and really bringing us up to date with all the developments in pancreatic and biliary cytology reporting and the WHO terminology. The book should be out later this year, but you know, this gives you an introduction. You know, you heard it here first on the BAC spring tutorial, and also, you know, you need to perhaps let your clinicians know that this is the new and latest recommended terminology. And so maybe by the end of this year, once, you know, the copy of the book is there, and once you become familiar with its usage, you can replace the Papanicolaou Society terminology with the WHO terminology. But as you can see, and Maria has demonstrated, they're very closely aligned, very much just a step away in terms of what they have to offer. So let us see. We have questions in here from Leonie. Thank you, Leonie. And the question is, often cystic lesions can be paucicellular. Does this cause problems for KRAS testing? Is there a minimal cell yield, or is it based on free DNA? I'm sure we can discuss this together, Maria.
Yeah. So essentially with the KRAS testing, it's important to know that it's helpful in identifying a neoplastic epithelium, but it doesn't allow you to stratify the grade. And obviously, remember, with cystic lesions, the imaging is very important. And we can do KRAS testing on the fluid that's taken as a result. I'm not sure whether we require a certain minimal cell yield for it to be done on. Ash, are you able to?
Yeah, thank you. So yeah, great question, Lenny. And actually, there are publications to show, and there's data there to show that even in a non-diagnostic sample on sort of cytomorphology, it is entirely reasonable and possible to just look for free DNA KRAS mutations in the 12D codon. And this is associated with more than 90% of pancreatic cancers, including mucinous cysts. And in fact, if you combine it with the GNAS mutations, it's very specific for IPMNs. So you can use KRAS mutation studies even in the face of an acellular or a paucicellular or a non-diagnostic sample from a mucinous lesion, simply by sending off, a few drops of the mucinous fluid for molecular testing. And of course, part of the fluid would also go for CEA levels, which would be in the hundreds, if not thousands, if it's a neoplastic mucinous cyst. So thank you for that question, Lenny. Tony, can you state, just for the record, whether the anisonucleosis and the NC ratio you mentioned is a ratio of diameters or areas? Thanks. So, I mean, this is again a great question which we've encountered, whenever there is a terminology system that takes into account NC ratios, whether it's the Paris system or others, where you're looking at NC ratios, and it is actually areas, so rather than diameters. So you'll see the table of the Paris system, and you will see the different pictures there showing the NC ratios, and they have to do with area rather than ratio of diameters of the nucleus to the cell. So thank you. Lots of nice comments there for your presentation, Maria. And again, just something that I put into the chat box to hear back from some of our attendees, at least a few of whom I can recognize and who I know provide rapid on-site evaluation for their EUS FNA specimens of the pancreas. Are there any other attendees who are online and would like to state whether they perform or offer rapid on-site evaluation for EUS samples? And also, Maria, perhaps something for discussion as part of the panel. Who do we think should report on the pancreatic cytology specimens, particularly the cell blocks? And often these cell blocks are like mini biopsies, using a shark core or an acquire needle, so that they come out as sort of thin cores of tissue and look and feel much more like core biopsies. And there is, I think, a lot of discussion around whether these specimens should be reported by cytopathologists or histopathologists. What are your thoughts on this, Maria? And it would be nice to hear from the attendees as well, if you want to type into the chat box what your approach is or what your thinking is. Thank you.
Yeah, I think as cytopathologists, to keep skilled, it is good to see the spectrum of specimens. But I do agree with you, Ash, as with the invention of larger bore needles, and actually the FMBs now are almost the same as biopsies. And like I've said, especially with the pancreas, these are often the only modality by which we are getting tissue fragments to assess and often make an important diagnosis. I feel it's also variably dependent on the individual who's reporting the sample. So I feel that if you feel that you'd need to report it alongside a GI pathologist, it should be open, and I'm sure colleagues would always be willing to offer a second opinion. So, but I totally agree. I think you could say that actually should they be reported by GI pathologists if they're almost equivalent to biopsies, or could they be reported by a cytopathologist alongside a GI pathologist if another opinion is required?
Thank you so much. I think that's a great answer, because if you are reporting pancreatic brushings and FNA, most of the specimens or most of the samples that you will come across may be easy to diagnose, particularly if they are representative and adequate and good preserved morphology, and especially if you're attending these alongside the physician who's performing the procedure in the endoscopy unit. You have the added advantage of getting all the clinical and radiological information at the time you're looking at the sample, and that gives you enormous confidence in the diagnosis that you're going to make. So 90% of these may be readily diagnosed, or at least provisionally diagnosed at the time of performing the rows. And then once you get the pap stains later and the cell block, if you feel the need to show it to your GI or hepatobiliary colleague, then you could do that. But there's nothing really to stop cytopathologists from reporting on these specimens. But this practice can vary. And I think, as Dr. Glenn Dixon says, a collaborative approach between cytopathologist and histopathologist, if possible. And I think I agree that that's probably the best method. Thank you also to Dr. Louise Smart. Unfortunately, these shark core type samples are put straight into formalin and go to our histopathologist. So yes, I think that's the disadvantage if there is no on-site evaluation, or if these samples go directly into formalin rather than into some sort of a transport medium, which would allow a site of spin perhaps to be prepared from them, and then it might become a little bit easier. So these practices do vary. Dr. Catherine Harrison says biopsy and cytology are reported by the consultant reporting cytology, but we all report histology too. So, I mean, that is, of course, ideal, to be able to report cytology in the context of histology. And that is, again, Dr. Tracy Stevenson, Exeter has a BMS-led ROSE, upper GI EUS service. Many centers do not have pure cytopathologists, so histopathologists need to report these samples. So I think we're seeing a sort of cross-section of ways in which pancreaticobiliary cytology is reported across the country, and even more diverse, I expect, across the world. But provided there is a high quality service being delivered with an audit of the correlation between cytology and histology, regular MDM attendance to be able to get direct feedback on the reporting quality of these, so that patient care is not compromised. I think we want to ensure that a high quality service is being delivered to patients, and that can be achieved through several means. Bijal, I haven't overlooked your question. I was just taking the related questions first. So Bijal asks, is there any particular morphology tip to identify ductal cells from contaminants? Occasionally, you do not have the nice starry sky appearance of duodenal contaminants. What would you say, Maria? Any tips to identify pancreatic ductal epithelial cells from, as you demonstrated, duodenal epithelium, for instance?
Yeah, so with the ductal epithelial cells, you'll often find them admixed with your acinar cells. That's the first clue. The second is your ductal epithelial cells often have this honeycomb sheets, and you don't often get that with duodenal epithelial cells. And yes, I appreciate that you might not be able to identify the mucin, but by and large, your contaminants should be less than what you're seeing with your background epithelial cells. But I do appreciate that sometimes it is difficult to distinguish between the two. But I think the next thing is, once you've identified them as being epithelial, look for the atypia, so the nucleus fold, the background, the chromatin pattern, the nucleoli, as that will then guide further.
Thank you, Maria. And another question from Dr. Dixon. Simple, practical question: EUS needle out or in when making on-site slides? If the needle is out, do you wipe the needle with gauze to remove possible GI contaminant? One of our clinicians is adamant that this should be done. Any comments? So from our observation, the needle is not really wiped. We like all of the material on the slide and in the cell block, and regardless of the difficulties that the presence of these possible contaminants might have, I think we don't want to lose any valuable diagnostic material. We don't want to really throw out the baby with the bath water, as the saying goes. So we would like everything that we can have on the slide or in the needle washings for a cell block, and then we can sort out what's contaminant and what's not. So certainly in our practice, we do not wipe the needle. Thank you. Any other questions or comments from the audience, from the attendees? It's great that there have been so many practical points that have been raised as a result, whilst also introducing our attendees to a new and upcoming morphology system. So I don't see any more questions coming in. Are there any comments from Maria or Tony before we move on? Okay.
Sorry, I've just asked one question, which is just obviously you've talked about distinguishing duodenal epithelium from neoplastic epithelium. Can you also say something about distinguishing gastric epithelium in lesions sampled from the stomach, with distinguishing it from mucinous neoplastic stuff in the pancreas?
Yeah, so essentially, first of all, it'd be imaging, because most of the mucinous neoplastic cells are arising from a cyst. But also with the gastric epithelium, they tend to have that mucinous cap, which is often evident. So you have basally located nuclei and the apical mucinous cap. And obviously, if you have mucinous neoplastic cells, by definition, they'll either have low-grade atypia or high-grade atypia.
Okay, that's great. Sorry, I just very briefly. Before I was a doctor, I was a physicist. So this whole thing, the reason I asked the question about NC ratio, frequently in the documents, it just talks about size. And as a physicist, you say, well, what do you mean by size? You mean, 1 dimension, 2 dimension. So it's worth clarifying, I think. So a 4:1 area is actually a 2:1 diameter. I think sometimes in pathology we get a little confused about stuff like that. But that's why I asked it.
Yes, very good question.
Excellent. Maria, thank you so much.
Thank you very much.
Okay, and right, so it is my great pleasure now to introduce our guest speaker for the tutorial, Dr. Danijela Vrdoljak-Mozetič. Danijela is Assistant Professor and Head of the Clinical Department of Pathology and Cytology in Rijeka, in beautiful Croatia. She is the President of the Croatian Society for Clinical Cytology and also the Secretary General of the European Federation of the Cytology Societies, or the EFCS, of which the BAC is also a member. Danijela's interests include gynaecological and HPV, but also other areas of non-gynaecology, including serous fluid cytopathology. She's also passionate about education in cytology across Europe, and very much a leader in promoting this through her active contribution through the EFCS and also other societies. So Danijela, welcome. I'm really wish you were here in person in London as we had planned, but that was not to be on this occasion. But thank you for sparing your Saturday for us today and to take us through the cytology of peritoneal serous fluid in gynaecological oncology. So really quite a specific topic. Thank you so much.
Yes. Thank you, Ash, so much. And thank to the BAC for inviting me. It is a great pleasure for me and opportunity to share our experience in peritoneal fluid analysis and the way how we do it in our hospital. Now I will share the screen. This is... do you see my screen? Is everything okay?
Yeah, looks good.
Yes, yes, thank you so much. But first, I would like to take opportunity for a few minutes to talk about the European Federation of Cytology Societies, as we call it, EFCS. So what is EFCS? It is non-governmental and non-profit organization. It was founded in 1969 as a scientific association of European National Societies of Cytology or Cytopathology. And now, in these days, we have 26 full member societies from Europe, including BAC, of course, and 3 affiliated non-European members. So the membership works like this, that all individual members of respective national societies are the members, in fact, the members of the EFCS. So all of you members of the BAC are in fact the members of the EFCS. So I would like, I like to share this with you. So what are our missions and objectives? Promoting cytology as a discipline, offering professional training, issue recommendations with regarding to the training and qualification and practice in cytology, encourage exchange of knowledge and experiences, promote different projects, offer advice to official health institutions. So we have connections with the OEMS, organization of doctors, specialist doctors in Europe, and of course encourage friendly relations between our members. We also organize congresses, tutorials, workshops, and webinars on a regular basis. I would like just to guide you through our activities. We have this year EFCS tutorial. This is tutorial held on microscopes, the unique event of this kind, I think, throughout the Europe and the world. It is in Toulouse in June, and we have Cytology, European Cytology Congress in Budapest in October, and also it will host the Kuwait. This is examination especially designed for the screening of the PAP tests for the cytotechnologists. And I would like to announce, this is the fresh information. We just agreed to have the next, it will be the 3rd joint EFCS webinar, but this time between the British Association for Cytopathology and Finnish Society of Cytopathology. It will be held on the 31st of May, and you will all get an information and the program soon. Next year, the next year Congress, the congresses are held on an annual basis, will be in Germany, in Leipzig in June. So all of this information, you can look at our website in details, and also many other contents. So now I will go with my topic, and thank you, Ash, for introducing me. So I'm here in Rijeka. As you see, this is my hometown where I live and work, and it is situated on the northeast coast of the Adriatic Sea. So we are so happy and privileged to have this nice scenery every day. I work in a clinical hospital center Rijeka. This is academic institution, and it is really connected with the medical faculty of Rijeka. And in this picture on the right side, this is our old hospital, and on the left, this is our new building, in which we hope that we will move by the end of this year, so we will have a nice new pathology and cytology lab. So what about the serous effusions of the or body fluids? Any serous effusions that we look at, they are rich with cells. Cells are floating. They spontaneously exfoliate or exudate in this fluid. And this is exclusively cytological material and cytological diagnosis. So this is why I love it so much. We can say in any cytology lab, serous effusions presents high proportion of the routine specimens. So many cytologists really have it on the daily basis on their microscopes. On the other hand, interpretation is sometimes difficult, especially with only morphology, but with ancillary methods, which I will show you, it can become easier and more precise. So, cytology of the peritoneal fluid specifically is used in the diagnosis of various pathological conditions, but the main purpose is to assess the findings of the malignancy within the peritoneal cavity. It is important in preoperative diagnosis, intraoperative assessment, determination of the stage of the malignant tumor, and for postoperative monitoring. According to the protocol from our institution, during every surgery on the tumors of the ovaries, tubes, or uterus, peritoneal fluid must be routinely taken for analysis. In our hospital, we have Department of Gynaecological Oncology, which is the central or referral center for the whole Croatia for the malignancies of endometrium or uterus and tubo-ovarian malignancies. So we really take care for all our guidelines and protocols. So what procedures do we use? We can use aspiration of acidic fluid by laparosynthesis, aspiration of acidic fluid during surgery, or peritoneal lavage of peritoneal surfaces with saline, which is then aspirated. And all these fluid samples are processed in cytospin and as cell block with immunocytochemistry performed when needed, of course. So samples are fresh, and samples are immediately delivered to cytology laboratory. If it's not possible, we have to store it in the refrigerator on 4 degrees Celsius. Recommendation is to send us 70 to 75 milliliters or less if it is a total volume obtained, but usually we do get about 50 milliliters. We receive it in syringes or in cups without any additives. How do we approach our material? We immediately perform 2 cytospins for NGG or Pappenheim stain, Mengrenal Gimsa or similar, and 6 alcohol fixed sediments for Pap stain. We check and read in the meantime while we wait for the first slides. We check and read the patient history and referral diagnosis, of course. Then we look at the NGG stain slides, and in that moment we decide on additional sediments, cell blocks, preparation, or other methods, maybe molecular. So this is this is our workflow. So this is how it looks like. We use cytospin, and this first line staining, I usually compare it with the rose, but it is not on site because it is like fast, like evaluation of the material in order to process it while it is fresh. So it takes about 15 to 20 minutes. It looks like this. You are all familiar. We can use small funnel in which we can put up to 1 milliliter, or mega funnel in which we can analyze up to 6 milliliter of the fluid. So we sometimes we also analyze our fluids during the operations intraoperatively. The procedure is the same as previous, with the difference that we use fast staining for the fraction of the material. For the two slides, we use something like Diff Quick or Hemacolor. We use Hemacolor. I don't know, maybe you have some other brand of the fast staining, and we have also the procedure for the fast pap staining. In that occasion, we usually issue preliminary report and call to the operating room to just tell the surgeon what we see. So if intraoperative finding is negative for malignancy and clinical diagnosis is malignancy or suspicious of malignancy, all material is processed later in cytospins, LBC, or cell blocks. And if clinical diagnosis is benign, we stop at this stage. So depending on finding and cellularity of the first sediments, we decide if abnormal malignant cells are sparse, it is better to do additional cytospins, alcohol fixed for pap stain for later immunocytochemistry, because cell blocks will be sparse. We can predict that our cell blocks will be scant and sparse, and we wouldn't find any target cells. If abnormal malignant cells are abundant, we proceed to cytoblock for immunocytochemistry, and cytoblocks in this situation are usually of good quality. So depending on the cellularity, depending on the number of atypical or malignant cells, we decide how to proceed, cytospins or cell blocks. So for cell blocks, we use clot method. If any naturally clot is formed, we just put it directly in the cassette, as well as any fragment macroscopically observed. It is more frequently observed in acidic fluid. Clots are usually yellow and like a gelatin, so we just put it in a cassette. And if we don't observe any clots, we use classical agar method for any other method, which is in routine practice in different laboratories, of course, but we used to use agar method. And for immunocytochemistry, we use histology protocols. This is cell block with the agar method. Fluid is in eprouvettes. We proceed to centrifugation, discard supernatant, and later we fix the material with formalin, and then agar solution is prepared in thermostat, poured into fixed cell concentrate. Cell pellet is forming. We need at least 4 hours for that, and then we cut the set pellet usually by half and put the cut surfaces downwards in the cassette. So cassette is submerged in formalin solution, and paraffin block is processed as usual. So this is how it looks like usually. So we sometimes, but really it is our standard procedure. We use immunocytochemistry on cytology, on cytospins or smears. But before any use of any antibody, we have to validate it on pap stain preparations. It works well, but you need to validate each antibody. So why do we use pap stained preparations? Because we can select the slides with the target cells. You can see them. So this is the big advantage of using the pap stained smears. Of course, on cell blocks, we decide after we see hemaloeosin if there is enough target cells to proceed with the immunohistochemistry. But often we use combination of both, whatever looks better. So what cells do we analyze? Of course, you know that we have mesothelial cells. We can see atypical or tumor cells, if any. Usually there are some inflammatory cells or reactive changes. And of course, we always observe other features like background, necrosis, mucus, anything. So mesothelium is a single layer epithelium lining the body cavities. It looks like this. On the left here, you have the cells floating in the fluid, stained by May-Greenwald Giemsa. These cells are round with round nuclei and abundant basophilic cytoplasm. In peritoneal lavage, sometimes you can see like sheets of the mesothelium cells, and here you can appreciate the like this polygonal shape of these cells. This is a histology example. So how does it look like when it is negative for malignancy or benign? You can see here mesothelial cells, here stained with the Papa Nicolau stain, and here with the May-Greenwald stain, here and here, with the round nuclei, abundant basophilic cytoplasm, sometimes with a little bit dense rim, and sometimes with cytoplasmic protrusions, as you see here in this cell. Here we can see background of macrophages with vacuolization of the cytoplasm, some lymphocytes, granulocytes. So this is like a usual, how it usually look like with the finding of negative for malignancy. Another picture you can appreciate here. You can see here nice mesothelial cell with the oval nuclei, but regular nuclear membrane and basophilic cytoplasm. This is also negative for malignancy. Sometimes we have reactive mesothelial cells, like you see here with nucleoli and with some overlapping of the nuclei, with some irregular, like a cluster with some spaces in between. So we can be a little bit worried when we see the cluster like this, almost looks like papillary cluster, but we can use some immunostains to just prove that it is mesothelial cells, to prove the phenotype of this cell. So this is on a cell block, calretinin staining, which is positive, and also this is the staining of calretinin in cytospins in cytology, so it looks the same. Another example of reactive mesothelial cells, we have here a little bit anisonucleosis, anisocytosis with nucleoli, big nucleoli, and also few cells almost look like the synapse ring cells, but we all know that mesothelial cells, when they stay for a long time in the fluid, it can look, they can look like this, and this is the consequence of the degenerative changes. So when we have a preparation like this, we can do calretinin, in which we can prove that these smaller cells are really mesothelial cells, and also macrophages that really develop for the mesothelial cells. Then they can be positive for CD68. You can see it here. So these cells are not like epithelial cells. They are macrophages. So sometimes we only have purulent fluid with only neutrophils often disintegrated with necrosis. So you may say this is inadequate, we don't have any target cells, we don't have mesothelial cells, but you have to report it immediately. You have to call your surgeon, because this has a great clinical significance, and it can be really an acute and life-threatening condition. So you have to call and report and say, okay, I have a pus in abdomen, so this is emergency situation. So another nice example of negative for malignancy slides. We have benign mesothelial cells in sheets, often seen in peritoneal washings, in lavage, so here in Papa-Nicolau stain and here in May-Greenwald stain. The next I wanted to show you, these are also negative for malignancy, but these structures are called collagen balls, and these are really benign mesothelial cells with the collagen inside. They usually like line up the collagen material. So we see it in peritoneal fluid, but not in really rarely in pleural effusions. But these are not some kind of acinar structures of some kind of metastatic cancer, but these are benign mesothelial cells. So we can also see endometriosis effect in a peritoneal fluid when we see the macrophages with this pigment, which is really coarse and dark. So we report it as signs of endometriosis, or sometimes we have inflammatory changes with these multinuclear inflammatory histiocytic cell. When we see these cells like glandular structures with these microcalcifications, we can assume that this could be endosalpingiosis, but sometimes we report it as atypia of undetermined significance, and we can really relate it in some cases with the cases of endosalpingiosis. Also, when we see the similar cells with psammoma bodies, but the nuclei are not so polymorphic, they are regular with smooth chromatin, with small nuclei, we can also report it as atypia of undetermined significance, favor borderline serous tumor. So this is how it can look like when you have borderline serous tumor. Another example of the cells originating from the borderline serous tumor from our cases, and you can see here psammoma bodies which are typical for the serous tumors. The next example is malignant with papillary adenocarcinoma of the serous adenocarcinoma of fallopian tube. You can see here large nucleoli with irregular chromatin and large anisonucleosis and anisocytosis, and these small papillary structures typical for the serous adenocarcinoma. Another picture. This was in fact a case of a woman who went on a hysterectomy for the myoma of the uterus, and our gynecological oncologist observed serous fluid and just sent it to analysis for routine analysis. They didn't suspect anything, and this was our intraoperative diagnosis, and of course they looked better and found some small tumors on the peritoneal surfaces, and it ended up like high-grade serous cancer. So it is really useful that we can report intraoperatively our finding. So the next example is mucinous adenocarcinoma of the ovary. You can see here the large papillary structures with the signet ring cells inside the structures with the mucin. When you see such cluster with the dense eosinophilic material inside, you can suspect clear cell carcinoma of the ovary. This is a typical raspberry body consistent with clear cell carcinoma of the ovary. So another example of malignant cells with the cherry red nuclei. This is typical for the serous cancer, psammoma bodies. And of course, we can always use cell block, especially on acidic fluid, when we have to give our diagnosis before the operation. So you can see it here. This is PAX positive, VT1 positive, and this is hemelaun-eosin, and this is P53 positive, which give us diagnosis of the high-grade serous carcinoma. This is a combination that we use routinely. Another example with malignant cells in round acinic forms, PAX8 positive and P53 positive, and calretinin really is positive in mesothelial cells lining tumor cells, which are negative. It is rare, but sometimes we do see the granulosa cell tumor. This is a tumor composed of the small cells of the specialized stroma of the ovary, and this is typical Kohl-Exner body. You can see here this light eosinophilic material, and the cells are like in a rosette around this material. This is called Kohl-Exner body, and this is MGG. This is Papa Nicolau, the small cells with a really sparse cytoplasm. Usually, sometimes we see mucinous adenocarcinoma. You can see here like this honeycomb that our colleague previously described in the pancreatic cytology. We can just say it is like drunken honeycomb. So we can use immunocytochemistry. It was example that the cells were so sparse. You can see here abundant mucinous material and just a few malignant cells. And here, and we used immunocytochemistry and cytospins, and this was CDX2 positive, and the origin of this tumor was colonic cancer. So this is example of malignant alveolar rhabdomyosarcoma, very, very rare. We didn't use here any immunocytochemistry or histochemistry because the patient had the tumor removed, so every other analysis were done on histology. You just can see how it looks like very, very pleomorphic cells. In peritoneal fluid, occasionally we have metastatic breast cancer, and usually it is highly cellular, like in this example. The cells are single, just in some kind of sheets, and on cell blocks you can do all. You can do the differential diagnosis, like proving that it is of the breast origin, and also all other markers that you need to type the tumor: progesterone, estrogen, Ki67, and HER2. And after our analysis, this patient received a specific hormonal therapy, and I think she is well. She recovered, and I think it was 5 years ago when we had this diagnosis. Really rare, but Sometimes you can observe non-Hodgkin lymphoma. This was primary gastric non-Hodgkin lymphoma. You can see here atypical high-grade lymphoid cells. This was the part with the morphology, and now I would like to talk about the FIGO classification and the role of the cytology in the staging of the ovarian, fallopian tube, and peritoneal cancer. So, FIGO classification has a detailed clinical and pathological descriptioners. It has stages 1 to 4 with substaging and includes tumor location, intraperitoneal spread, lymph node status, and presence of metastasis. Currently, we use 2018 revision. So it corresponds with TNM classification, but in our country, our clinicians are used to use FIGO classification. So in FIGO stage 1, cytology is very, very important. So stage 1 means the tumor is confined to ovaries or fallopian tubes. 1A, tumor is limited to one ovary with intact capsule or fallopian tube with no tumor on ovarian or fallopian tube surface, and no malignant cells in the acidic or peritoneal washings. So you have to be certain, you have to analyze all material that you receive to say that it is negative. So 1B is the same, with tumor limited to both ovaries, and 1C, 1C3 is when you have malignant cells in the acidic or peritoneal washings. So this is the most important place for cytology for the staging of the tumors of the ovaries. In stage 2, we don't have any cytological analysis that is included, so we will move to FIGO 3 stage. We do have, but it is not so much used, that tumor involves one or both ovaries or fallopian tubes or peritoneal cancer with cytologically or histologically confirmed spread to the peritoneum outside the pelvis and or metastasis to the retroperitoneal lymph nodes. So in some occasions, we do receive the lymph nodes or some biopsies from the peritoneal cavity and make imprints, or it can be done by the fine needle aspiration of deep organs, so it can fit in a stage 3. Cytology is very important for the FIGO 4 stage because we can detect distant metastases, excluding peritoneal metastases, especially in pleural effusions. So if we have pleural effusion with positive cytology, it is stage 4A of the ovarian or tubal cancer. Of course, also stage 4B, if we have parenchymal metastasis and metastasis to extra-abdominal organs, which we can prove by fine needle aspiration. So what is the sensitivity and specificity of peritoneal cytology? Specificity is high and sensitivity is variable as you look at the literature, but I think it can go higher than this. So we did a study in our hospital. We wanted to analyze our peritoneal fluid findings and reports, and in benign and malignant tumors of the female genital system, and also to reclassify the findings according to the International System for Reporting Serous Fluid Cytology, TIS, of course. We retrieved the data from 766 patients during the year 2018 and 2019 in two-year period. So we analyzed ascitic fluid, preoperative and intraoperative, or peritoneal lavage fluid washings, which are always intraoperative. Sample sizes varied between 2 and 45 milliliters. And we always have a routine cytospin with MGG and Papa Nicolau. Aliquot of the sample is analyzed intraoperatively, as I already mentioned, is our way of doing things. And just in some cases, we did immunocytochemistry and cell blocks. So what were the clinical indications for the surgery? Usually it was suspicion or confirmed malignant disease, ovarian or adnexal cysts, or tumors, abdominal pain, or diagnostic procedures in sterility workup. So we use the international system for reporting serous fluid cytopathology. I'm sure that you are all familiar with that, so I won't describe you all these categories, but just to state that we used these categories. These are our results for the ascitic fluid. So we had only 3% of non-diagnostic. Just a little bit more than 50% of negative for malignancy, only 3.8% of atypia of undetermined significance, 0 suspicious for malignancy, and 41% of malignant diagnosis. For the peritoneal lavage or washings, the situation was different. We had only 1% non-diagnostic. Majority were negative for malignancy, almost 90%, 2% atypia of undetermined significance, 1% suspicious for malignancy, and 8% malignant. So we looked further for the categories of atypical and suspicious categories. So the most frequent outcomes for atypical and suspicious findings were finally malignant or borderline tumors in histology. So these findings are really serious and it have to be taken in account by clinicians. We also had malignant findings with non-gynaecological origin. The majority were from digestive system, and some from breast, one non-Hodgkin lymphoma, and one even from the lung. So these were metastatic tumors. So we calculated our sensitivity and specificity, and I'm really proud to say that we had really good numbers with really great positive predictive value and negative predictive value. And for the majority of the cases, we knew the follow-up or histology. So the conclusions for our study, that is that cytology of peritoneal fluid is a necessary diagnostic procedure in the protocols for gynecological tumors. And in our experience, and according to the results, peritoneal fluid cytology has a high value and diagnostic accuracy in the detection of a local spread of malignant processes in the peritoneal cavity. And when we use the international system for reporting serous cytology, it was very, very successful and gave us better clarity in the evaluation of our work. So this is my last slide. I would like to say that fusion cytology, whether it's pleural, pericardial, or peritoneal, is challenging, often complicated, but highly interesting and rewarding area of cytology. From simple exclusion of malignancy, assessment of some critical clinical conditions, to staging and the follow-up. So please dive in with confidence. So thank you so much. I will now end my presentation and wait for the questions.
Thank you. Thank you so much, Danijela, for an excellent presentation. with wonderful results of your study. And perhaps I should jump in straight away
Yes.
and ask you to submit your study to Cytopathology. And I'm sure
Yes.
Louise and Philippe will join me if it hasn't gone anywhere else. We would love to see that published in Cytopathology. Okay, so we
I will
right
find
here.
time. Yes.
Thank you. Yeah. Well, I mean, I was just really struck by the beautiful preparations. You took the time to talk about the cytopreparatory methods, which is so important in getting the high quality material that we want to have to be able to make diagnoses confidently, and for cytology to become a joy that it is to report when you have good quality preparation. So congratulations to you and to your team for these beautiful preparations.
Thank you.
Also, I wanted to ask, how did you take these photographs? Are these images from scanned whole slides, or are these just individual clicks down the microscope?
These photographs are from the microscopes. I used my camera and microscope. I don't want to advertise, but but I can tell you later. This is equipment that I will use later for the video like workshop. So
the quality is amazing.
Thank you so much.
Absolutely beautiful photographs, so much detail, such high quality. And then, of course, it was fascinating to hear about the application of rapid on-site evaluation, or pretty much the equivalent of a frozen section. Rather than looking at a biopsy, you are just spinning down some fluid intraoperatively and providing information that your clinicians want from you and act upon intraoperatively. So that's a great message to send out, because we're used to perhaps using imprint cytology in the context of intraoperatively, but to actually spin down fluid, for me, it's certainly a novelty. We have some.
Oh, really? We use it for years.
Amazing. So good to hear that. We've got a breast surgeon who says, well, if we have breast cyst fluids in the clinic, can you not just spin them down in the clinic and tell us if it's a benign cyst, rather than us having to wait? And I just thought, I'm sure it's something that could be done. And you have demonstrated to me that yes, it is being done.
I will send you our recipe.
Thank you. No, it was just beautiful to see.
We have results in about 10 minutes or so.
Amazing.
5 minutes spin, and then just few dips for the staining. For the MGG is really fast, a little bit longer for the pap stain, about 2-3 minutes. Fast pap stain procedure. We also developed ourselves.
Oh, right.
And some tips and tricks, so it can be done. Yes.
Well, the results are absolutely amazing, and it was just beautiful to see those raspberry bodies and cherry red nucleoli, a sign of spring is here.
Yes.
That was absolutely stunning. So much for my comments, and then of course they are pouring in the chat box as well. If there's any other questions, please, okay, here they come. Glenn, thank you. Any tips on distinguishing between high-grade serous carcinoma and primary peritoneal carcinoma using ancillary testing? And it's an open question to you and to any of the panelists as well.
I don't think so, on based on morphology or immunocytochemistry or anything that we can do on cells or the tissue, but even our histopathologists really rely on the finding inside the peritoneal cavity. If they have the largest tumor mass in the omentum compared to the ovaries, they can then diagnose it as extraovarian serous adenocarcinoma. So I think that's the way how we do it. I don't know, maybe you know more about this, but
no, it's exactly the same as far as I'm aware here in the UK as well. And if there are any gynae histocytopathologists in the audience, please feel free to, it's a small group. Yeah, to add, you could even unmute and speak. I think it's a small group, but do type in your thoughts if you would like to. So no, I agree. We very much, based on morphology and ancillary testing is very difficult, and it is often just down to the MDM to make that distinction.
Yes.
I'd just like to,
Tony. Yes, thank you.
Yeah, just to go back to the whole business of the intraoperative stuff, because like Ash, I mean, I've done intraoperative dabs on nodes and masses and that kind of thing, but we've never done intraoperative fluids.
Yeah.
Do you do it on? What's your criteria for the intraoperative assessment? Is it every procedure, or just the ones with a high suspicion of malignancy, or how do you screen those?
We just do a few sediments, just an aliquot of the material. So our clinicians know that, and they know that the final diagnosis, when we sometimes process all the material, can be different. But this information is very important because it usually really fits in with the final diagnosis. So we do process 1 milliliter or 2 milliliter of the fluid, and just stain it fast and look at the microscope, and what we see, we report to them. We call them on the phone and say, okay, this is negative, this is suspicious, we have some atypia, we will tell you later what it is. We are just really so honest with each other, so it works very well. Or we have malignant cells that they maybe didn't expect, or inflammation. It is all important for them during the surgery.
Okay, but it's every procedure.
Every procedure, procedure.
Okay.
Yes, this is like we set it up in our clinic, so we are in the same building, so it is possible for us.
Okay, and just as a detail, they don't do frozen sections on tissue at the same time, do they? Or do they?
Sometimes yes, sometimes yes, sometimes yes. And we all usually here with our histopathologist, we call them to consult, really not to be too different sometimes in our intraoperative reports. Yes, it could be really.
I can see the issue.
Yes, sometimes, because of each other. Yeah.
And,
two bodies, one mind. Yes.
Yes. Well, actually, the next question also kind of addresses that issue to some extent, I think. Dr. Louise Smart asks, if you see low-grade serous morphology in a fluid, possibly from a borderline tumor, how do you report it? And do you wait for the final histology? And that was something I was going to talk to you about, because it ties in with the international system as well, and its recommendations. So I'd love to hear what you do.
This is the detail that really international system helped me so much. So we report it as atypia, of course, of the serous epithelium, something like that. Yes. And we can suggest in some. If we have really nice preparation, a lot of cells, we can suggest, okay, it could be borderline, but we wait for the final histology, and really we don't want to say it is malignant if it's not. You understand? We really wait for the sake of the patient to have all the results or all diagnoses in one line. So
absolutely.
I mean, use it like this.
I think that is, in fact, the appropriate terminology, using atypia and to have to wait for correlation with the final histology and the immunostains. And in fact, one of the things that we encourage is, the correlation with the main surgical specimen, because these specimens are, coming along with a big gynae specimen, the tubes and ovaries and lymph nodes and omentum, multi-part specimen, and it can take a while before that is cut up and reported. But before it goes to the tumor board meeting or the multidisciplinary meeting, to get to the right stage, particularly for the T1 tumors, if you've got bland cells, is it just, Müllerian epithelium, or is it, some other low-grade tumor? Of course, you showed some beautiful psammoma bodies, and I think if you've got those, then they do give you a clue that you might be dealing with a borderline serous tumor. But otherwise, yes, we would do the same. We would report that as atypia, as Syra comments in the chat box. Shouldn't that be AUS?
Yes.
TIS classification, and so that would be the atypia, and then you would sort of, do a cell block and maybe immunostains on it to see whether those cells have the same immunocharacteristics as the primary ovarian tumor.
Yes.
So
we sometimes use that, especially P53. And
absolutely.
if we have a wild type of reaction, so this is a low grade or borderline, so we can use that sometimes. If we have really abundant atypical cells, maybe morphology is a little bit worse than we would expect. We use P53 for the confirmation that all of these cells are not high grade, of course, that are low grade or borderline.
Yeah. So Sumaya comments, should we label it involved by serous neoplasm low grade? Yes, I mean, that would depend on, that is correct. And, in correlation with the surgical histology and the ancillary work I've done on those specimens. So, sorry.
Okay, that was the point. We can suggest, but we wait for the correlation.
So, I mean, your correlation with the histology is, near perfect. It's, close to 100, and you haven't actually used the suspicious category at all. And so there's a high degree of sort of confidence on the cytology, obviously, and given the quality of your preparations and and of course the diagnostic expertise, you've got almost half and half benign or malignant. There's just 3 cases which were atypical and no suspicious. That is almost, that's perfect.
Thank you so much. But I swear these are our results. These are not intraoperative results. These are final results.
Of course.
So sometimes during the operation, we can say that we have a few suspicious cells, but we really work on the residual of the fluid. To have cell blocks or multiple cytospins to really differentiate if it is some kind of reactive mesothelium or some epithelial malignant cells or anything else. So we really try for the final report to differentiate between benign and malignant, to keep it as low as possible. Yes.
Yeah, and that also is what the international system, the TIS, recommends, that you should or could easily adopt a 2-tier approach to the suspicious category. And intraoperatively, it is helpful enough to say, yes, we're dealing with some suspicious cells, we need a bit more time, but we will get there once we have the cell block and once we've done the immunostains. But then to be able to upgrade them once you've got all the material that you need, including the ancillary, or downgrade, absolutely. And that's often the problem with the suspicious category, that the cells look high grade, but they're either not well preserved or they're not enough in number to be able to confidently call malignant. And for that, all you need is a little bit more time, maybe a few more preparations, and a cell block to be able to upgrade them from suspicious to malignant. So there's a couple of questions now. Can we differentiate between ovarian serous and uterine serous on cytology?
Okay, it is possible. And in fact, the first case that I prepare for later for the video microscopy is a case of the uterine serous adenocarcinoma. So
we'll hear more about
suggest,
it later.
Yes, to wait.
We will hold that in suspense for a little while. Okay, it won't be too long.
Okay.
And then Dr. Bijal Shah said, excellent presentation. Just a question, ER/PR HER2 status on fluid cytology, cell block, formalin fixed,
Yes.
whether it is okay to report, and what your views are on reporting hormonal status on metastatic breast fluid samples.
Okay, so we have a policy in our institutions that all these samples we prepare it to the stage of the cell block and for the Gata 3 or anything else to really prove the breast origin, and then we proceeded to our breast pathology team. And they do all the ER, PR, HR2 staining, and they really look at it and like decide what is the type, subtype of the tumor. So this is accepted by our MDT for the breast cancer. And really, our team, histopathologist for the breast cancer, they accept it, and so this is the way how we deal with it, because it is not so rare, especially in pleural fluid. So we always do the cell block and then give them the cell block and paraffin block to do the rest.
I think, sorry, just to come in on that.
Yes.
There has been, I think the issue often is HER2, isn't it? Because there's been an issue about whether you can do HER2, whether you can reliably do HER2 immunohistochemistry on cell blocks. And of course, it depends how they're fixed. If it's an FNA, it may well have been fixed in alcohol first and then formalin. I think it's not. It's accepted that FISH is always pretty much okay, but I think sometimes there's an issue whether immuno for HER2.
It is always on cell block and without alcohol fixation.
Okay.
It's only formalin.
Fine.
Fresh material in formalin.
Sure. Okay.
Without alcohol. Yes.
Wonderful. And Sarah Khan comments, we report this in our lab. This is really helpful for oncologists to proceed based on results, provided we have good cellularity. Sorry, Sarah, you're talking about breast or ovarian cancer? Breast. Okay.
Breast.
Yeah.
Yes.
Yes. Okay. Excellent.
It is like freshly put in formalin, so
yeah.
It shouldn't be so different. Yes.
No, absolutely. Okay. I don't see any other questions in the chat box. Yes.
One more thing, just one more thing. Just again going back to the intraoperative thing. So
I'm so glad that you liked it. Yeah.
It's a country I haven't been to, as it were. Yeah.
I will send you all procedures.
What do your operating surgeons do with the information? I mean, do they? How often do they change what procedure they do? Do they just say thanks very much? That's what we thought, or do they actually? Does it actually make it? In enough cases, make a
sometimes yes. Sometimes yes. Like the example I showed you, the indication for the operation was myoma, and we found malignant cells, and they looked and did the biopsies, and that they find some kind of little tumor masses that they didn't observe before.
Okay.
So yeah, sometimes yes, sometimes yes.
Okay.
Excellent. Okay, we're just a couple of minutes away from past, but I suggest that we take a 15-minute break now. So starting at 1:45 the hour, it'll be 11:45 in the UK. 1:45 for Central European time.
Yes.
And,
okay.
And so we'll see you, in about 15 minutes.
Okay, see you.
Thank you so much.
See you.
Okay. Right, okay, well, welcome back everyone. And it's almost 1:45 the hour, but I'll just give you some idea of how we're going to play the afternoon session. So Danijela will run her slide seminar first using live microscopy. So she's going to be actually using glass slides on the microscope from her office and showing us a few cases. You can type in your questions or your answers to those cases in the chat box, and we'll monitor them for you. And we'll go for maybe about 45, 50 minutes, see how many cases we can cover during that time. And then after that, Maria will run a mock exam style session. Many of you do have your exam coming up next month, and we thought it would give you a little bit of practice to do some exam standard type of questions. And again, feel free to type in your answers and also ask any questions. And as a panel between Maria, Tony, and myself, we will try and field those questions between us. Okay, so Danijela, you are ready?
Yes, I will now share my screen. I hope it will work. Do you see it?
It is, yes.
Yes. Oh,
yeah, we see
wonderful. So you are now seeing exactly what's on my microscope here.
Lovely.
Yes, sure. So this was the first case I planned to present you today. It is a female, age 68, with the clinical diagnosis of postmenopausal bleeding with thickened endometrium by ultrasound and endometrial cancer suspected by primary care gynecologist. So we also had a pap test with the report of adenocarcinoma. And after that, our gynecologist in our clinic performed endometrial curettage, which was only necrosis on the histology. So they observed that she has acidic fluid, and this is the preparation of laparocentesis. So macroscopic description was yellow turbid fluid. And first we made the cytospins with NGG and Papa Nicolau stain. So you can see here the cells which are malignant, of course. It is not a problem to say it's a malignant and possibly adenocarcinoma of the high grade. So here you can see a few mesothelial cells, normal, benign, some neutrophils, histiocytes and macrophages and lymphocytes in the background, and a lot of malignant cells with large nucleoli and abundant cytoplasm with vacuolization. So here, another group. Or there's like adenoformation, large nucleoli. So this is not a problem to make an intraoperative diagnosis of malignancy if you need to, but this wasn't our task here. We wanted to find out what is the origin of these cells. You can see here really big malignant cell. So let me just show you these cells in Papa Nicolau stain.
I was just about to ask.
Yes, sure. We always do both staining. So here, the same cells, and with the psammoma bodies here. You can see the lamellar structure of the dark red psammoma bodies here.
Beautiful. You can actually see the laminations on it.
Lamination.
On
Yeah,
you
can see it here.
Yeah.
So this is typical for the serous type of the cancer, and by the cells you can see it is a high-grade carcinoma. So just a few other cells, smaller, bigger. Here another cluster with the psammoma body.
It's nice to get our eye in the first case with something that's high grade,
yes,
so that we can appreciate the difference, you know, with the benign cells in the background in terms of their size and architecture. So
yes,
great.
Sure. Thank you. So the next step was to make a cell block. So let me just. So the cell block here. Okay. So this is HE. It was not so cellular as we should expect looking at the sediments, but I think enough for our purpose, for the differential diagnosis. So we have our target cells here. So we did a PAX8. And it is nuclear staining. So this is positive.
And is this
Also
superimposed on the PAP stained slide, Danijela? Because you said that you do
yes,
your immunostains on the PAP stained slide.
Sometimes on a PAP stains, but if we use cell block, we don't use.
Oh right,
we don't duplicate. Yeah. This is cell block.
Of course.
We don't duplicate, of course. But this is all on cell block.
Got it.
You can see it here. This is nuclear, strong nuclear positivity of PAX8. So this is typical for the serous type of the cancer. And the next thing, we applied WT1, which should be positive. Also on the nuclei, but it is not. You can see some positivity in cytoplasm, but it is non-specific. It is negative in the tumor cells, BT1. So we can suspect it is not primary ovarian. So, of course, we applied P53. We already know it's high grade, but we wanted to diagnose it with certainty. So it was positive. Not so beautiful as the previous, but you can see positivity.
Yeah. I mean, that's the beauty of the nuclear immunostains. They are, you know, it's much easier to interpret, much easier to sort of read compared to cytoplasmic
course,
stains.
Or membranous, yes.
Or membranous ones, yeah.
So what we wanted to do, we suspected this is a serous, high-grade serous cancer originating from the endometrium, which was in necrosis, if you remember. And then we did vimentin, of course. But the problem with vimentin is everything is positive in acidic fluid on vimentin. But we were lucky that we had so big and pleomorphic malignant cells, so we could find them. This is malignant cell, big one. Nuclei, of course, are negative for vimentin, but you can see here cytoplasmic staining that is positive in this tumor cell. Also here. But in the background, you can see lymphocytes and macrophages that are also positive for vimentin, but also these tumor cells is positive. Okay, so here another one, and here these are our cells. So our conclusion was that this is a high-grade serous cancer originating from endometrium. So if you agree with me, that's the answer for questions at the end of my talk. So the patient was she went to surgery and her uterus removed, but there were no signs of high-grade serous cancer in the uterus. And we finally assumed that this tumor mass, that it was totally necrotic, originally was high-grade serous cancer. So we discussed it on our MDTs. It was a lot of convincing between oncologists and cytologists and histopathologists, but they finally accepted our diagnosis, and they treated her with the protocol for the high-grade serous cancer, and I think she is still alive and well. So that was my first case.
Thank you.
Do you have any questions?
I can't see anything in the chat box yet, but I think it was just
maybe
beautifully explained, and it was, you know, it was a good sort of a warm-up case, I think, to get people's eye in into the.
I hope so
into
that
the
the others
and
will
the morphology.
Yes. Yeah. I really have a pap smear from this lady also here. So I can just show quickly the pap smear. So these are the same cells in the pap smear.
Amazing.
Yes. Here also almost the same.
Yes.
Cherry red nucleoli.
Yes, yes, yes.
Okay. Okay, so this was the first case. I just move it here. So next one is also acidic fluid with a patient with ovarian tumor. Also, I can start also with the pap smear.
Yeah, absolutely.
Yes.
Yeah, this is gynaecology. You've got
gynaecology, yes, of course. We always look all the materials. So this is conventional pap smear. Maybe you forgot about conventional, how it looks like.
Well, I mean, you know, a good quality conventional is as good as a liquid base. So,
yes,
you know, the morphology is so beautiful here.
Yeah, this is a trophic squamous epithelium. And suddenly here you have this round ball cluster with the not so large cells, but with the nucleoli. So we reported it as atypical glandular cells and ordered further workup. So this was only thing in a pap cells. So now acidic fluid. Okay. Here you have a really highly cellular sediment in cytospin and a lot of clusters and some individual malignant cells. So this is a papillary cluster, MGG stain, surrounded by macrophages. And if you can see here, this is psammoma body and how it looks like in MGG. It really doesn't stain at all. It is like whitish structures.
Just sort of refractile.
Refractile, yes. Yes, and some individual malignant cells. So with vacuolization in some parts, and this dense like clusters of the tumor cells. So
huge three-dimensional overlapping nuclei, every feature of malignancy.
So in the pap stain, the same structures, but the cells are not so pleomorphic. They are more monomorphic, but with these large nucleoli, red nucleoli. When you see red nucleoli, it is always an alarm in any kind of tumor adenocarcinoma. So three-dimensional papillary structure here, the tumor cells. Okay. And then also the cell block, but I have some on cytology. I will show you immuno later. So this is HNA. When we have our cells here, enough of them, papillary structures, or like this, like ball structures. So
very nice glandular
glandular,
formations.
yes.
And
yes. In
and this-
cytology, it is like ball structures. In cut cell block, you have this like glandular morphology with the lumina inside. So this was really maybe an easy case for us. We usually use PAX8, VT1, P53, and maybe calretinin to exclude possible, maybe mesothelioma, but it is so rare in a peritoneal fluid, in peritoneal cavity. So this is PAX8, nicely stained nuclear. Here. Here, we, as the opposite of the previous case, we have VT1 positive. So it proves the tubovarian origin. This and P53, because these cells were a little bit small and monomorphic, but the P53 was so intense and expressed in all tumor cells, so it defines the tumor as high grade. When it's a mutant type, here it is a high expression or in all cells, or other situation will be that we have null expression with no expression at all. So both situations are really a consequence of the mutant P53, and it is considered high-grade serous cancer. If we have one cell positive, next cell negative, we will call it wild type, and it is not then a high grade, it is then low grade or borderline. So this was high grade, no matter that it was so, I should say, monomorphic.
No. So how often do you come across tubo-ovarian carcinomas in a pap smear, Danijela? Because obviously you picked up on the atypical glandular cells on a pap, and that was quite a finding. And it's and then to be able to sort of trace it back to these, it's a great case.
Yes. It is not often, really, I have to admit, but in a large screening lab, you can accept it a few times in 1 year that we can pick up something like this. We have about 35,000 pap smears in 1 year, so it is really, really totally rare. But yeah, we are always excited when we pick up something like this and suggest maybe to check up on ovaries. In pap smear, when you have such a atypical glandular clusters on a clean background, you can sometimes suspect extra uterine origin. So it means from fallopian tubes and ovaries. And recently, I think 2 weeks ago, we had a case like this. And everything was negative, curettage and ultrasound, and no tumor was found on imaging. But our colleagues, gynecologists, decided to go on the laparoscopic surgery, and finally they found a primary tumor of the tubes, of the fallopian tubes, that it was, I don't know, less than 1 centimeter. So yes, it's worth to to try to find the origin if we find some atypical cells in pap smear. Yeah, it is serious. It is serious finding. So we did the calretinine just to be sure that it is not some rare mesothelioma of the peritoneal surface, but it was negative. As you can see it here, you can find a few mesothelial cells that are positive. So you have inside of your slide, you have positive control. Negative and positive. A few mesothelial cells. Okay.
Great.
Great. So that's it. I will just move it. Okay, the next one.
Do you ever use this setup for your rapid on-site evaluation of the cytospins in theaters? I wonder.
No, not for
Okay.
now, but maybe
Okay.
we will plan it for the future. Yes, when we go to the new lab, we plan a lot of new things. I hope we will be able to implement.
Yeah, no, absolutely, because the quality of the image and the microscope and everything is so great. There's no reason why.
Yeah, why not use it on a rapid on site? Yeah, sure. So we have more time. I will just show you the next case, female, age 70, with the clinical diagnosis of bilateral ovarian tumors. So also acidic. So we have a mucinous material. And here we have some signet ring cells and also in clusters. You can see it here. So some macrophages, lymphocytes, not so atypical by the look of the nuclei, but certainly you see them. You see them. It is not very cellular, but you can see here mucus, these like strings of mucinous material with the cells inside or nuclei inside. So this kind of preparation have to raise a suspicion of some mucinous tumor.
Yeah, I mean,
like
one
a
of
lake.
Yes, absolutely. I mean, I think if you see mucin, you should look hard for the cells, because the cells themselves could be quite bland, couldn't they? If it's a mucinous adenocarcinoma. And in fact, one of the the categories and the conditions in the international system was if you just see mucin, and even in the absence of pleomorphic cells, you should raise the possibility of, pseudomyxoma from either a GI or gynae primary, because mucin in the peritoneal cavity is an abnormal finding.
Yes, and this is the case, such as you described. So this was MGG and PAP.
Yeah, that's what I'm waiting for, because it's easy on the Giemsen. I was wondering if it's just as easy on the PAP. Wow, yeah.
You can see the lake of the mucin also in a PAP. It is like bluish rose and some bland, as you say, cells, but they look.
But they are, they are signet ring. Yeah,
signet ring. Yes. Yeah.
big mucin vacuoles in them, indenting the nucleus, pushing it to the periphery.
Yes. So also a
indeed.
few of these cells here. But you can really wonder, are these tumor cells or macrophages or something?
That's right. Yeah,
but
absolutely.
It is
they are much bigger than the surrounding
they are bigger.
lymphocytes and mesothelial cells. But if in doubt, obviously you can do some epithelial markers.
Sure.
But I think it's important to at least suspect that they might be there and to look hard for them.
Yes, you can see here this mucinous material. There is a lot of it.
Yeah.
And when you go down, maybe this is a little bigger, atypical cell with a nucleoli. So we went further with this case. Okay, let me see, what is this? So this was the case that we used cytology for immunocytochemistry. I hope it's still good, because during time it can deteriorate. So this was done on the cytospin, because the cellularity was so sparse and we didn't want it to lose the cells in a cell block. So this was let me see, CDX2. CDX2. So it's not very beautiful, but you can see one. Maybe I will show
I'm sure there are others
another
as well,
one. Yes, I think it is not so here. Okay,
they are there. Yeah,
there are a few cells with the nuclear positivity, and here and here. With the time it is yes, we know that the immunocytochemistry can really go pale. So I think I have it photographed. So here we have
that's much better.
That's much better. I didn't find it at once. Okay, this is totally clear that we have nuclear staining on cytology, but because we validated, of course, all the most frequent antibodies that we use, we validated all on the cytology.
Amazing. And these were these on a PAP stain slide. Do you destain the PAP, or do you just superimpose the immunostain on?
We just superimpose. We don't need to destain.
Okay.
So CK20, of course, we used. Okay, this is okay. This is nice. So cytoplasmatic, positive, CK20, also used for the gastrointestinal origin. Not so much here, but we have this previous cell, and here the two cells, really strong staining. So the two antibodies for the colonic origin were positive. So we wanted to see what about PAX8 for the origin of the ovarian, and it was negative. You can see it here. So, and also,
so you would need to do a panel of markers that includes both GI and gynae, particularly if the primary is unknown and it's just presented like this the first time.
Yes, we do the panel. We really change the panel as we need, as we suspect to have the cases. So CK7 was plus minus not so convincing. Okay, so we really suggested that it was the mucinous carcinoma. We suggested gastrointestinal origin. So it was, in fact, histology confirmed mucinous adenocarcinoma, metastatic in ovaries, also suggested gastrointestinal origin, and the patient went to chemotherapy. I'm not sure if they found a primary, but she is really diagnosed as the mucinous adenocarcinoma of gastrointestinal origin.
All right. Although the initial presentation clinically was that of ovarian,
ovarian
masses, like
bilateral masses.
Krukenberg,
yes.
tumors,
Krukenberg,
really.
yes,
Yeah.
yes. That was typical. So
fascinating. So this could be even an exam case for those of our attendees.
Oh, really?
Sitting the exam, because you could get a mucinous adenocarcinoma.
I will send it to you. You can use it.
To then have a differential diagnosis of if there's a history of an ovarian tumor, but in the presence of mucin, not to forget that it could be something non-gynecological as well. It could be a gastric or a pancreatic or. So there's a question in the chat box. Would we do MMR immunostaining microsatellite instability if it's primary colorectal?
We can suggest it, but only if MDT ask for us to send them material. In some situation, we did send the material. Again, when we get to the level of totally specific further investigations, we give our material to our team for gastrointestinal pathology. So yes, if they ask us, we can give them material, and then they will decide if it is enough cellularity or anything to make such a specific analysis. So
absolutely. I think this is somebody who might also be interested in it from the sort of exam point of view. If you're suggesting that it could be gynae or GI, you would put down your panels, and then you could who knows, there might be a hidden little mark there for you to suggest that it could be a primary colorectal, and then also to say, if there's material in the cell block, you could.
Yes. We more and more frequently now include in our report about the material, about the cellularity. I always write down, okay, we have cell block and we have, I don't know, approximately 1,000 cells in the cell block, or we have abundant smears in the case of the indication for a further molecular studies. So
that is such good practice, because we also, sometimes when we get a request for, say, a PDL1 or an MMR on a case that was reported a while ago, it is so nice to have somebody already put in the report, that block number 6 is the best one for future ancillary tests, and they don't have to get the slides in the report out again to choose which one to do it on. Someone's already done that. And also a very good point that you make about, conserving material and not, just splashing out on the immunostains to, cover melanoma and everything under the sun, and then finding you haven't got the material remaining for something really useful like MMR if it's requested. Great points.
Yes, but we use it more frequently in the pleural fluids and in the pulmonary cytology. More frequently than in acidic or peritoneal fluids.
Sure.
Because we have situations with the thoracic tumors or pulmonary tumors that the only material that we have that we will have in the future would be cytology material.
Brilliant.
FNAs or brushes or effusions. So
absolutely.
So especially we are careful when we have pleural fluids. So the next case will be.
I'm just responding to a comment in the chat box for someone who's saying, will we have access to the recording of this discussion? And yes, you will. We'll let you know how soon, and we'll try and put it out before the exam, which is exactly a month away as it happens. So we'll have a little chat after the meeting to make the recording of the entire meeting, including the discussion, available for people who want to maybe just listen to it in 3 weeks' time or something. So,
okay,
but
yeah.
thank you.
So the next example was intraoperative lavage, and the final diagnosis was high-grade serous carcinoma, histological diagnosis, and this was a peritoneal fluid with, I think you all agree, these are mesothelial cells, but we have to really be sure that these are not malignant cells.
And I would say to the trainees and exam going candidates to just, you know, in your mind, run through the features of mesothelial cells, you know, basophilic cells with a two-tone cytoplasm with gaps or windows between
gaps and windows.
And, you know, the overall NC ratio is low, the nucleus is central, very monomorphic appearing. They could be multinucleated or binucleated.
Or
And
some anisonucleosis like here.
Yeah.
And also we have here like a big cluster of smaller cells. The mesothelial cells, when they desquamate, can also look like this. But we wasn't so sure, because we knew that the patient have a malignant ovarian tumor. So we wanted to be sure. So these are all like mesothelial cells, a little bit reactive. Okay, this was MGG. Oh, now pap stain. Yeah, this is typical how it looks like in peritoneal washings. You have like sheets of small mesothelial cells. They can also look like this. And also here you have some larger cells, a little bit reactive. But this is all mesothelium.
It's just coming off in sheets with some smaller
and
groups
really,
and a few dispersed cells.
And look at this. I don't know really what this is.
Yes, there are some interesting sort of contaminants and artifacts that creep into peritoneal washing.
But I think these are cells. And I think these are also like mesothelial cells, but they look so strange, like little worms stretched out, yes. But you can observe something really, really, and here some kind of elongated cells. So I was a little bit worried what all these cells are, like with different features. So we really did immuno on the cytological samples. So this is PAX8. And oh, this is really, really pale, but everything was negative. So, okay, we were relieved. We really thought that all these cells are of the, here you can see the negativity of the mesothelial origin. And it is totally important because of the staging of the disease. If we declare it negative, this is 1A stage of the ovarian tumor, and this is so important for the further therapy for the patient. So PAX8 was negative, and also VT1, it was all. Oh no, this one was a little, sorry, this was positive.
What immunostains is this again? Sorry, Daniela?
VT1.
Okay, WT1, right.
Yes, VT1 was positive. but it could be in the fallopian tube epithelium. Okay, now P53, and it was negative. It was negative, and you can see here it was a wild type. A few cells are positive, and this was really the most important result for us. So it was negative. So we thought in the end that these strange cells could be fallopian tube epithelium, that it was shed in the peritoneal cavity. So this was really difficult case for us, but finally we pronounced it negative for malignancy because we didn't know what are these strange cells that you saw previously with this elongated nuclei. So
I see. So, and there was no sort of clinical correlate to explain these on the histological sample.
No, not really. Maybe during the operation, with the manipulating with the tubes, some of the epithelium of the tubal epithelium just shed into the peritoneal cavity. So we explained these cells like this, like we decided, and we just pronounced it negative for malignancy. So,
so they may have
really
been called sort of atypical to start with based on the morphology, because you don't know what they are, but they look bland, they're not high grade. So call them atypical, and then you resolve it by doing the ancillary workup and correlating with the histology. Excellent.
That was our point for this case.
Fantastic.
So immuno is sometimes helpful, but sometimes it's totally confusing. So be careful with immuno. You can't solve everything. You really just need to take responsibility.
Yes, that's really good advice. No, absolutely. That's what it is about. And at the end of the day, it's your name at the bottom of the report. And so somebody asks, could we use other mesothelial markers like D240, calretinin?
Yes, of course, we can use. Maybe I had them here. Yes, we use them.
And also, so would this be negative or AUS? Well, if you're able to, able to say with certainty that these aren't malignant, you would then have to say what sort of cells they are. And if you can't say what sort of cells they are, then it's probably safer to call it atypia, and then do your markers to then pronounce
something negative
on them. So it could be a sort of a two-step process here on the were epithelial markers also done? Did you say, Danijela, to see if we did PAX8, which was negative, wasn't it?
Oh, yes, I think we do here. I have, maybe I can show it. BR-EP4.
Okay, BR-EP4 was negative, right? Got it.
Yes.
Somebody was just asking if epithelial markers.
So here,
BR-EP4 is a good one.
This is mesothelial cluster. We are sure. So we here had a really immuno that was really confusing, but nothing matched anything. So finally we decided, okay, it's negative.
Absolutely.
So maybe it's a little bit case that is difficult,
it's a bit challenging,
but if it doesn't match with nothing, you just go with your sense.
Absolutely.
So okay, so
I think we could probably do one more.
One more? Okay, maybe I will show you now borderline. But I only have morphology here, so I won't be embarrassed with immunochemistry. This is a borderline proved.
Right.
serous borderline, and our diagnosis, cytological diagnosis, was atypia, papillary proliferation, could correspond to borderline serous tumor. So this is how we can classify. Okay, let's see. What do we have here? So just a few large cells. I'm sure we have better preparations to show you. Maybe the next one. Here. So here you have a small papillary cluster with slightly atypical cells. Not too much, but maybe better in a pap smear. Here. Yeah, just a small cluster of very slightly atypical cells. Here, this is the best, I think, to show you the cells originating from the borderline serous tumor. It was confirmed later on the histology. So this is the situation in which we will wait for the histology and then correlate, and then yes, okay, we have some atypical cells that can correlate with the diagnosis. So this is it, papillary cluster with small cells, small nucleoli, vacuolization. So
excellent.
And when you compare, this is mesothelium.
I think just recognizing the two separate cell populations is central to this. Otherwise, they could be missed completely. But when you see them next to each other, you see the difference.
This is mesothelium, the flat, yes. And this
then
is
the more three-dimensional
nucleoli.
And of course with the samoma bodies.
This is borderline.
Also, is there a cell block on this as well,
no,
Danijela?
No,
okay, so this is just on the
this is just
cytospin.
Morphology. This is only morphology.
Yeah.
So yes, sometimes we do extra cell blocks just to have sample for the investigations or education, but this one we have only the cytospins. And here you can see here, this is all mesothelium, polygonal cells. So
I mean, this would be, the sort of thing which, in a test situation, such as in an exam situation, it's a test of morphology. You don't have the cell block, you don't have the immunostains. You have to give your opinion on what you've got on the PAP and GIMSA. So this is a good practice for the attendees to say, to pick up on the fact that there is a two-cell population here, which looks very different to the mesothelial cells, and in the context of an ovarian tumor. And of course, morphologically, the helpful feature, if you see the samoma bodies, then, again, to call it atypia would be fine. So because you haven't got the high grade morphology, I think you should use the suspicious category, Sarah, if you see high nuclear grade morphology. But of course, you would then suggest, doing the immunopanel, which would include P53 to say that. But
if you
on morphology, on morphology, low grade.
Yeah, low grade. So if we received this material as pre-operative acidic fluid, I suppose we will perform cell blocks and more ancillary testing. But this was intraoperatively taken, so we just waited for the histology to match.
Yeah, absolutely. I mean, that's another good point. If you
clinical setting,
absolutely, don't have to duplicate your immunostains in the same department. And
Yes.
this, particularly with, say, pleural biopsies for mesothelioma, you've got a nice cellular pleural fluid, but there's also biopsy. And it's really tempting to say, well, it'd be such a lovely case if I did the immunostains on the cell block. But then you think, well, my histology colleagues are also doing it.
Yeah.
So I don't have to do it in every case. In cases like these where, the morphology is fairly diagnostic, it's worth probably just to wait for the histology and just correlate based on morphology.
Yeah.
Excellent learning points there. Daniela, I can't thank you enough for all of those fabulous cases for the slide seminar. And it was nice that we were able to do it like a kind of a multi-header, digital multi-header session. And with a little bit of a chat, I think also helps.
Yeah.
And there's, compliments to you coming in for, the quality of the images. Lots of thanks coming in. And thank you so much for making time for us on a Saturday.
So much.
And we wish we, could go out for a meal after this if we were in London, but, that's for another time. And I hope you're staying online for another hour or so.
Yes, I would love to hear the cases from Maria.
That would be wonderful.
Yeah,
Thank you so much.
Something. Okay, always something to learn. There is. Yes, sure. Thank you so much. Thank you for listening to me. Thank you. Bye.
Bye for now. Okay, Maria, the stage is yours now. But you're going to run this session slightly differently. So Maria is going to share some scanned slides with you. Again, these are kind of exam standard cases, and we'll have a similar discussion. We'll give you a history, and we will then maybe not describe things for you quite as much as Danijela very kindly did, but we will leave for you to, we'll give you the history, give you a few seconds to look at the slides, a PAP and a Ginza, and then you can type in your answers or any comments or questions, and then we will have a little discussion around them. So Maria, what's your first case?
Yes, thank you. So what I've done is I've selected good examples of our daily reporting in cytology, which also make good examples for the exam. So the first case is a 76-year-old male with a unilateral effusion, and so these are cytospins of pleural fluids. So please go ahead and put in the chat box what your diagnosis is and any thoughts on it. So I'm going to start at low power and I'll go on to higher magnification so that you can assess the cytomorphology. I'm just going to point out some cells that we commonly encounter in pleural fluids, and you can try and identify those. If I take you to the PAP.
Good idea to open all the presentations in one go, Maria, rather than pausing to open them one by one. Very good. So this is the PAP cytospin on this pleural effusion.
That's right. And I'm just showing you a few representative fields which are the same in general. Okay, so do you want to use the chat box to make any suggestions?
Is there any history that you've given? Sorry, I might have missed out on the history.
Yeah, the history was a 76-year-old male with a unilateral effusion.
Oh, right. Yes, thank you. Okay. Unilateral effusion, 76 male. What are your thoughts? benign, malignant, any specific type of effusion, lymphocytic. Okay. Okay, benign, abundant lymphocytes, macrophages, benign mesothelial cells, maybe saying lymphocytic effusion. Okay, so Maria, what's the answer?
Yeah, absolutely.
Everyone seems to be going for a
essentially,
lymphocytic.
Yeah, it's a reactive effusion, and I think given the abundance of the small mature lymphocytes, you could go further and call it a lymphocyte-rich effusion. So just going back to sort of morphology, so this cell here that I'm pointing to at is a reactive mesothelial cells, and as Dr. Chandra initially described, it's important to think of the morphology of your normal cell constituents. So just run through a few features that allows you to identify the cell as mesothelial in origin. So that two-tone cytoplasm, the frilly border, the round nucleus. It can be eccentric or central. It maintains the nuclear to cytoplasmic ratio, and sometimes they could be binucleated or multinucleated. Similarly, we can get numerous macrophages, which I did show on the MGG, but essentially they have foamy, bubbly cytoplasm. They might have the kidney-shaped nucleus, and they're rather uniform. And these small mature lymphocytes, which if you find a good companion comparable, which is often a red blood cell in my case, you can see it's of similar size. So these are reassuring features that it's a reactive effusion. So calling it a negative or reactive effusion and a lymphocyte-rich effusion is the correct diagnosis. For those that are sitting the exam, I think the important thing is to have about 2 or 3 points to write in your comments after you've put the diagnosis, because essentially if you have the diagnosis correctly, that will score you probably a 2.5, and then you want to try and maximize your points, especially in those cases where you may struggle or might not be able to give a concrete diagnosis. So in a case like this, if you've called it a lymphocyte-rich effusion, you could comment on the causes of lymphocyte-rich effusion. So can anyone use a chat box to give some examples of what may cause a lymphocyte-rich effusion? Yes, excellent. So it can be associated with TB, connective tissue diseases such as rheumatoid. We can often find it in patients who've got cardiac failure. A lymphocyte-rich effusion is also common post-surgery, and viruses, absolutely. Yep, and I think also you could state that you can use the term lymphocyte-rich effusion when more than 50% of your nucleated cells comprise small lymphocytes. So yeah, that's excellent, correct. Any other questions with regards to this case?
Low-grade lymphoma. I was waiting for that question to come up.
I think it can be in the differential. However, it's important that we rely on our cytomorphology. So with the low-grade lymphoma, you'd expect to see more of a monotomous lymphoid population, but you also need to be guided by the clinical history and also imaging. So does the patient have widespread lymphadenopathy? Is low-grade lymphoma in the clinical differential? So I don't think, as a reflex, I wouldn't send all my lymphocyte-rich effusions for flow cytometry, because one, it's not necessary, and two, we just bombard flow cytometry with lots of these samples. But I think you need to be guided by the clinical. Ash, is there anything else that you'd like to say with regards to
no, absolutely. I think, as you said, in an exam test situation, the test is of the morphology, and on morphology, this is a mixed population of predominantly small mature lymphocytes, but with a good admixture with transformed lymphoid cells, occasional large cells, but also mixed in with mesothelial cells and macrophages. So this is quite a mixed population, and it looks like a reactive population. With the high-grade lymphoma, of course, you would recognize, because all the cells will be large and will completely overtake any other cell populations on the slide, and it'll be just wall-to-wall packed with large lymphoid cells. The problem comes when they're all very much the same size, and they're bigger than your average mature lymphocytes, so they're kind of intermediate sized, and then you could have a differential diagnosis of a low-grade lymphoma. And that would be the instance where sending the sample for flow cytometry or making a cell block and doing a panel of immunostains to either exclude or confirm a low-grade lymphoma. But based on the morphology, on this case, I wouldn't go down that route. I think here the morphology is that of a reactive lymphocyte-rich effusion, and so they shouldn't be that differential, in my opinion, for this case. I think we can go to the next case now, Maria, just in the interests of time.
Yeah, the next case is a 60-year-old gentleman, and this is a right level 2 PET avid lump, which has been performed, FNA has been performed of the lump. So if I start off with the NGG and the low power impression.
Yes, in the context of a one-stop clinic with rapid on-site evaluation, we've just had to get used to making evaluations on the GEMS alone, because that's all you have at the time. And if you're, rapid access one-stop clinic where the patient's going to be given the report by the clinician, then you have to give some sort of a provisional report based on the GEMS or morphology. The PAP usually comes the next day, and you'd assign the case out the next day, but you have to be able to feedback something to the radiologist and also to the BMS, the cytopathologist, to say, I think, let's make another slide, or put the next couple of passes only into needle washings for a cell block, because I may or may not need to do some ancillary workup. And of course, then also verbal or a written report to the clinician who's going to see the patient. But this is all that you might have. However, in the exam, you will also have a paired PAP together with a GEMS for FNA cases.
Yeah, so I just want to bring to your attention, so on the NGG, just to consider a few things. So one is the background, so what sort of background you're seeing, and two, what are the cellular constituents of what we're seeing. And we can see that we've got two cellular constituents. We've got these and these. And linking it to the clinical history, remember we've said it's a level 2 and it's PET avid. And I will move you on swiftly to the PAP. Again, noting the background, and then also what else we have, the cellular material on the slides. So if I stay on this magnification, just assess the cells, sort of their characteristics, the NC ratio, the quality of the cytoplasm, and also your background. Does anyone want to use the chat box to make any suggestions at what this could be?
Someone just wants to be reminded of the history again.
Oh yes, the history is a right level 2 lump, which is PET avid. Oh, I'm very impressed. I didn't catch anyone out. Yes, this is correct. This is a Walthin's tumour. So I thought I'd give this as a good example, because often sometimes you're not told that it's sampling from the parotid, and it's important to bear in mind other things that we may encounter at the level 2, not just lymph nodes, and to obviously not misinterpret the lymphocytes as a lymph node and then see these epithelial cells and then call it a metastatic squamous cell carcinoma. So that's very good and prudent. So as you've all correctly identified, you can see this beautiful granular background, and with the small mature lymphocytes sprinkled in the background. And then we see these beautiful oncocytic epithelial cells, as you can see, sort of like strip sheets where they've all got uniform nuclei and abundant granular cytoplasm. And they sometimes can have a prominent nucleoli, but by and large are uniform. So things to consider here is that sometimes Walthin's tumours can have squamous metaplasia, but these are often non-keratinizing. The second thing to consider is that these can be PET avid, so they're often found incidentally for workup of other lesions in patients. In terms of the exam, calling it a Walthin's tumour and using the Milan classification of neoplastic benign would be the correct thing to do. And then to maximise your points for further comments, you could say that it's, for example, the second most common is salivary gland tumour. It often arises in males, in smokers, can be bilateral. You can have squamous metaplasia, and you can excise it if the patient is symptomatic. Any questions on that case?
I think someone's asking if they should use them. Milan terminology, and I think, yes, you should.
Yes.
Even if it's labeled level 2, as Maria pointed out, you can get salivary tissue at level 2, normal salivary gland tissue there. So, and the PET avidity, thank you, Tony. Yes, the reason why these incidental tumors are picked up on PET, because they're full of mitochondria. And so, with metabolic activity, which is what PET is a measurement of. Thank you.
Next case.
Okay.
Yeah, so case number 3, this is an 80-year-old female with a right-sided pleural effusion, and we have pleural fluid. So I just want to go on low power, so the cyto spins, just to give you an overview. And then I'll zoom in on certain features to try and identify the cellular constituents of this pleural fluid. I just bring you onto the PAP.
And some comments starting to come in. Somebody talks about Mulberry clusters. Some talk about metastatic carcinoma, adenocarcinoma. Seems to be a definite, yeah, everyone's going for adenocarcinoma, apart from maybe one. Atypical mesothelial proliferation. Panel for meso versus adeno. Mesothelioma. So quite a mixed bag of replies there, which makes it a great case for discussion.
Absolutely.
Maria,
so
well
I think,
chosen.
Yeah, so this is actually a case of an atypical mesothelial proliferation, and we can talk about what allows us to distinguish them being mesothelial over adenocarcinoma, but I totally appreciate that it can be a differential, and sometimes we can have adenocarcinomas that mimic mesotheliomas and vice versa. But essentially, as someone correctly identified, we had Mulberry-like clusters. I think they were better appreciated here on the MGG. So can you see that the outline are Mulberry-like, sort of humps rather than smooth? And then when we look at the cells, if you note that there's mesothelial cells in the background, and if you assess the quality of the cytoplasm, you can find that the cytoplasm of these singly dispersed mesothelial cells and those seen in the cluster are actually like for like. Similarly, if you get the nucleus, you can see that the nucleus are similar to what we're seeing in the single cell distribution. And then what I'll do is look for features of adenocarcinomas. So you will look for the absence of intercellular windows, but here I can sort of vaguely make out that we have some. And again, those are subtle signs of mesothelial cells in origin. The other sign is to look out for cytoplasmic vacuolations, which are often characteristics of adenocarcinoma. And I don't see those in these cells here. Also, the degree of pleomorphism. So these all look like, so they are variant, but they look like they're arising from the same population, so mesothelial cells. So I can identify this as mesothelial cell. And again, the cytoplasm quality is the same as is the nucleus. So I would identify these as mesothelial cells. Moving on to the PAP, again, we can see similar features. So this is a nice Mulberry-type cluster, typical of mesothelial cells. And we can see a spectrum of mesothelial cells. So we can see sort of reactive to atypical mesothelial cells. So what I would do, so I could call this an atypical mesothelial proliferation, or you could call it malignant, and then you do a cell block and immunohistochemistry. So if you're confident that you can identify these as mesothelial, then you wouldn't need to do a BER-EP4 or a calretinin, but that could be part of your panel. So a BER-EP4 or a MOC31, which would be positive in adeno and negative in mesothelial cells, and then a calretinin, a WT1 or a D240. And then once you've identified those as mesothelial in origin, you could then go on and do a desmin or an EMA, or also a BAP1. I know BAP1 aren't always easily available in all hospitals, but essentially loss of nuclear BAP1 staining is positive in up to 2/3 of mesotheliomas. And I think it's also important in the discussion of this case to say that you want to link it to the clinical history. So does the patient have a history of exposure to asbestos? Are there pleural plaques? Is there a concomitant biopsy that you can correlate with? Any questions?
So yeah, that's great. I mean, it's a great case for the sake of all the discussion that we've had. I think as an examiner, and if this was out, you know, in a test situation, we would at least want you, on the basis of the morphology, to identify this as a mesothelial problem rather than an adenocarcinoma, or having even a differential diagnosis of adenocarcinoma versus mesothelioma. So that would be like the best mark is, okay, on the basis of the morphology with the almost equal sized monomorphic looking clusters, you know, showing the features of mesothelial cells with the gaps in the windows, with the two-tone staining of the cytoplasm, with the lack of nuclear pleomorphism and the coarse vacillation of the cytoplasm. All of those words say to me that you are describing mesothelial cells, and the absence of you know, coarse vacillation of the cytoplasm or tightly cohesive three-dimensional clusters. And then the next step would be to say, you know, this is a mesothelial proliferation, depending on the history. This may represent mesothelioma, and then that you would do a panel, which includes, yes, BAP1, desmin, epithelial membrane antigen, and even to say P16 or MTAP deletion by FISH. For confirmation. And again, that is to demonstrate your knowledge. It doesn't mean that, you know, your lab is doing it on a daily basis, or, you know, whether you have or haven't got access to it, but in terms of just demonstrating your knowledge for getting that extra point, that's what we would expect. If your differential there is wider, but, you know, the description and the immuno panel that you suggested is reasonably small, to know that you will get to the correct answer, you know, you might reach the passing mark, even if it's not the best mark. So you might lose out marks if the further you're straying from a confident diagnosis of a mesothelial proliferation, which can then be confirmed as an additional step by doing a panel of immunostains. So that's the sort of, well, real life approach as well. If this came in on a Friday evening, and I had to put something out because the patient is unwell, there is no, you know, real clear diagnosis at the moment, I would probably put a report out saying it's suspicious for mesothelioma, or it's an atypical mesothelial proliferation. However, there are no features to suggest metastatic adenocarcinoma, and a supplementary report will follow. And then, you know, so over the weekend, the clinical team that's looking after this patient know that they needn't be hunting for a primary site from a metastasis, and that they should perhaps focus on mesothelioma more. So, and that's the same approach that you would have in an exam situation. That's the only advice I can offer here. If there aren't any more questions, we could go on to the next one.
Okay, so the next case is a 35-year-old female, and this is a left thyroid nodule which has undergone FNA. So again, this is a low power view, just to assess what we're seeing here in the background. and then I'll just take you to some areas. And then the PAP.
So in the context of a one-stop clinic, of course, with only the Giemsa, you would be able to say it's an adequate smear with with colloid and cells. And in the clinics where our BMS or cytotechnologists attend the FNA list with the radiologists, they're able to assess these slides and guide them as to whether further passes are necessary or not. And they might just take in a couple of dedicated passes only for a needle washing in case we want to do any a cell block or other ancillary workup. But in the one-stop clinic, you might just have the Giemsa. So yeah, we'll wait for your responses now.
Yeah, so please type in.
Type 3F, type 3F Hertel. Any other thoughts or offerings? Type 2 colloid nodule, type 2 benign. Okay, so there's a string of type 2 benign colloid nodules and a couple of type 3 F and Hertel cell nodules.
Yeah, thank you for your contributions and suggestions. So the correct diagnosis for this was a non-neoplastic thigh 2 colloid nodule, and going back to the other suggestions of a thigh 3F category. So the low power view is very important with thyroids because it allows us to assess the ratio of colloid to follicular epithelium. And here we can see abundant thin and thick colloid. So that's a reassuring sign. When I went on to higher power to show you the benign follicular epithelial cells, you can see that these are in sort of loose sheets and they've got a moderate amount of cytoplasm, but they're not oncocytic, so not Hertel cell, and I'll give you the reasons behind those. So they don't have well distinct cell membranes, they don't have granular cytoplasm, and often with Hertel cells, they tend to have quite round, plump nuclei and prominent nucleoli. And we can see here that they're in benign sheets, they're not forming all microfollicles that would suggest a neoplastic process. And we saw similar features in the PAP. I suppose for the purpose of the exam, a pertinent negative would be that there are no nuclear features of PTC, and your bottom line would be a benign thigh 2 non-neoplastic nodule.
Yeah, that's
Any
great.
questions?
I think, yeah, I know you've made all the great points there. I think, obviously, we're doing this in a mock test setting. We're giving you a few seconds to look at a slide and to, offer your thoughts. So very brave of you to, come forward and share those. It depends very much on what stains and preparations you're used to, but I think Maria would probably agree, and I'm sure many of the other participants as well, that Giemsa stain is really a huge help in the context of a one-stop setting, particularly for thyroid and head and neck and salivary gland lesions, because it shows up the colloid and it shows up the matrix of salivary gland tumors. It shows up mucin very, very nicely. And so these extracellular components are really helpful in making a diagnosis based on the Giemsa slide. But if you're training or working somewhere where all you get is a thin prep or only a PAP, then if you're not used to Giemsas, then that may be a reason why you may not have recognized that there is actually quite a lot of thick and thin colloid present on this aspirate, and that the cellularity is proportionate to that of the amount of colloid and that the architecture is predominantly macro rather than microfollicular, and that there are a few Hürthle cells admixed, in a heterogeneous population of follicular cells and other, thyroid follicular cells, but the dominant population is that of just bland follicular cells, few macrophages, bare nuclei in a background of thick and thin colloid, and so no architectural or nuclear features to suggest either a follicular or a papillary carcinoma. Are there any additional comments you can give in a case like this in an exam setting? Frankly, if this is agreed by the examiners as a good example of a colloid nodule, Thy2, then you don't really need to say very much. It depends also on how the question is phrased, and if it says that it was a suspicious nodule or something, then you could say, discussion at the MDM is advised in view of the discrepancy with the imaging findings, and so you could put in a comment like that if you are contradicting the history or the clinical data that is provided to you. But otherwise, there should be no need to say too much. Excellent. So we're on to our next case now.
Yeah, so our next case is a 67-year-old female, and this is an axillary lymph node FNA. So this is the MGG direct spread. So I'm just pointing out some cells here for your interest, sort of trying to understand sort of the morphology of these cells.
Okay.
And then if I take you to the PAP. Feel free to start making some comments on what the diagnosis is, or if you have a differential.
Okay, some answers are starting to trickle in now. Malignant, carcinoma, melanoma, medullary, lobular. We've got a good range of differentials there. Dispersed atypical single cells, eccentric nuclei, lymphoid background, plasmacytoid cells, differential diagnosis of melanoma, plasmacytic neoplasm, lobular breast, etc. Suspicious of metastatic.
Yeah. Thank you so much for all these suggestions and being such good, keen participants, because obviously this is all the ones that you suggested would be very valid and incorporated into a differential. But I'll tell you that the answer to this case was melanoma, and I will try and tell you some cytological hints that will allow you to favor one over the other. So I think the main differential here was whether it was melanoma or a metastatic carcinoma. So if we go back to, if it was a metastatic carcinoma, you're most likely for it to be an adenocarcinoma. So although you can get sort of a single cell population in the case of a lobular, and this is a female patient and it's an axillary lymph node, you would expect to see other features of adenocarcinoma. So more of a greater degree of nuclear pleomorphism, cytoplasmic vacuolations, and these are not features that are seen in these direct spread preparations. What we do see are singly dispersed atypical plasmacytoid cells, they have eccentric nuclei, they have high NC ratios and prominent nucleoli. I was trying to see if I could find a nuclear inclusion, which I could earlier. But then once you've identified them, then you want to look at other features that would help you solidify or confirm your diagnosis. So in the case of melanoma, look for those inclusions, look for intracytoplasmic pigment, and then also look for other clues going against an adenocarcinoma. But I appreciate that this could be in the differential. So if it was in the differential, a way that you could work this up would be by doing cell block and immunohistochemistry. So in your immunohistochemistry panel, you could put in a couple melanoma markers, such as melan-A, HMB45, and also a pancytokeratin, which would obviously be negative in the case of melanoma. You could also link it to the clinical or raise the question, does this patient have any skin lesions or any previous history of melanoma? And then also, in addition to this, in cases of melanoma, you can send off for BRAF mutations. Any questions?
Thanks, Maria. So I would just like to say that, you know, in this case, for those of you who have gone straight for melanoma are probably going to get the best mark, because although melanoma can look like anything, this is what it most commonly looks like. Plasmacytoid, dispersed population of cells lacking any configuration in glandular structures. There may be some suggestion of, you know, spindling of the cytoplasm. So, you know, this is what melanoma usually looks like. And of course, look for the pigment, look for the intranuclear inclusions. Obviously, in this setting where we're only giving you a few seconds to, you know, come up with your differential diagnosis, that's perfectly okay. In a test setting, I would say the best mark would be for melanoma being at the top of your differentials, because actually lobular will tend to have less cytoplasm. They tend to be smaller cells, and the nucleus tends to be filling up the cell. I think you're probably thinking of a plasmacytoid carcinoma of the breast. That's a very rare diagnosis to make. You know, statistically, if you see appearances like these, think melanoma first, and then depending on the confidence with which you're able to make that diagnosis after having spent a couple of minutes looking at the PAP and the Giemsa, putting them in some sort of an order to say, you know, I favor melanoma, and I would confirm this by doing, you know, 2 melanoma markers and maybe 1 pancytokeratin, such as MNF1162, to exclude carcinoma. And that might be just to, you know, because it's an unexpected diagnosis, and a metastatic melanoma often is an unexpected FNA diagnosis made by the cytopathologist for the first time, and particularly if it's in the context of a breast clinic where, you know, this is a young woman who's presented to the breast clinic. You know, the whole focus would be on excluding a breast primary, and so the, you know, to the breast team, you might have to say, well, actually, I think rather unexpectedly this is a melanoma, and I will prove it by doing the melanoma markers, and I will do a pancytokeratin and a GATA3, which I expect to be negative. So that would be the most sort of confident way of answering such a question, whether it's in real life or it's in an exam situation. But it's completely, yeah, absolutely, Tony. Thank you. You know, it's melanoma has caught all of us out at some point, and you know, just not to forget it in your differentials. And this is a fairly typical appearance of a melanoma. Lobular breast carcinoma doesn't really look much like this. A plasmacytoid carcinoma does, but that is very rare again. And so just doing a small panel of markers to start with, or if you feel confident in calling it a melanoma as your top differential, then do say that, and say that you would do the immunostains to confirm your diagnosis and to exclude the differentials. That you know, presents it with the greatest degree of confidence. And so, yes, LC5 you would use if it were in the context of a breast carcinoma. We are saying that this isn't breast carcinoma, that this is something else. And so in this case, you wouldn't be using the LC5 terminology, I think. Okay, if there aren't any more questions, we could go on to the next one. We're doing well for time.
Yep, okay, so the next case is a 50-year-old male with mediastinal lymph nodes, and this is FNA of a mediastinal lymph node. So if I start at low power, because this is actually quite characteristic of the example, and then I will start going on to higher power. So I'll point out a few things. So what's in the background, and then also the cells of interest. What sort of morphology are they displaying? Yeah, so it's an EBUS case. So it's a mediastinal lymph node EBUS case. Okay, and if I move you on to the PAP. I hope by now you've already got a sort of history as differential or even the diagnosis based on what you've seen on the MGG, and the PAP can just reinforce your initial impression. So I think I'll just stay at this magnification because it can actually show all the features. Okay, so thank you all for your comments. So this is an example of a metastatic small cell carcinoma, absolutely. So going through the features of what makes it a metastatic small cell carcinoma. So at low power, you can see the abundant sort of nuclear streaking artifact. And then as we go up into higher power to assess the cells, you can see that they're not clustering, they're loosely aggregated and they're singly dispersed. And then in the background, we can see lots of this karyorectic or apoptotic debris. You have this marked nuclear streaking. And then on the PAP, you can appreciate the nuclear molding, the scant cytoplasm, the stippled chromatin, and the inconspicuous nucleoli. So these all in combination are diagnostic of small cell. So in a case like this, you would call it a metastatic small cell or a high-grade carcinoma of small cell type, and you can perform cell block and confirmatory immunohistochemistry. So you could do some neuroendocrine markers such as CD56, synaptophysin, or chromogranin. You could also do a epithelial marker such as a CAM5.2 or AE13, and that often shows perinuclear dot positivity in small cells. And you could do a TTF1, which is commonly positive in metastatic small cell carcinomas of lung origin. And then if you do a proliferation marker, such as a Ki67, these will be invariably high. I think I saw a differential of a high-grade lymphoma. So this can be in the differential, but then I usually have a checklist of why it wouldn't be a high-grade lymphoma. So the first instance is with a high-grade lymphoma, the cells are actually larger than the small cells. So I often use the red blood cells as a comparison. So in a high-grade lymphoma, you'd expect them to be at least 2 sizes or 3 sizes larger than the red blood cell. They tend to have more cytoplasm than the small cell carcinomas. The high-grade lymphomas can have associated lymphoglandular bodies, which are the basophilic materials in the background, but sometimes they may not be present. And then the other feature that suggests a high-grade lymphoma over a small cell is the chromatin pattern and the nucleoli. So in a high-grade lymphoma, you get coarse chromatin, whereas in a small cell, it's stippled like what we're seeing here on the PAP. And commonly in a high-grade lymphoma, you can get multiple prominent nucleoli, and these are not features seen in small cell carcinoma. So I think that those are features that allow you to distinguish between the two. So I think this is a good example of a small cell carcinoma.
Absolutely, I agree. I think the top mark here would be for a confident recognition of the cytomorphological features of a small cell carcinoma, and to say that you would just confirm your diagnosis by doing the neuroendocrine markers. If you have a differential diagnosis, say with a high-grade lymphoma, to describe the features that Maria just told you about, to say, which of these features is there or not there that is resulting in your, differential diagnosis, and then how you would resolve it. So if you're able to, have a plan, demonstrate that you would have a plan to resolve the differential diagnosis and not just sort of leave it hanging there to say it could be a lymphoma or a small cell carcinoma and biopsy advised. That's not the that's not the best scoring answer. The best scoring answer is either a confident answer with some confirmation based on your knowledge, or a differential diagnosis with a plan on how you would get to a single diagnosis. So if you then have a small table there with your neuroendocrine markers and the appropriate lymphoma markers, obviously I wouldn't expect Hodgkin's to be in the differential. I wouldn't expect a CLL to be in the differential. Your differential here is with like a high grade a DLBCL type of lymphoma, but it just hasn't got the other features that would support it on morphological grounds. But if you're stuck, and if you really feel I don't want to risk getting this badly wrong, I think it would be safer to offer a differential. But then how I would resolve that differential, you would still get the pass mark at least. So that's in terms of reported in real life as well, if you have the differential, or at the time of rapid on-site evaluation and bronchoscopy, you really were stuck and thought, I can't really be 100% sure. I favor this to be a small cell carcinoma, but I want to rule out a high-grade lymphoma. I need a bit more time. And then, but you should be able to have that discussion or conversation with the respiratory physician. Thank you, Tony. Yes, absolutely. The other differential that comes into play is a basaloid squamous cell carcinoma, particularly if it's a head and neck lymph node, but also could be in a mediastinal location. Look for keratinization or more abundant cytoplasm somewhere. So yeah, all really valuable comments there. Thank you.
I just want to add a few comments. So if you have this in the exam as your further comments, this is your moment to shine and also show the examiners that you can link it to clinical presentation. So often these patients can present acutely unwell. They can present with pancreas tumor, so they can get SVC obstruction, and they can also present with paraneoplastic syndromes such as inappropriate ADH, so they'll have a hyponatremia. So I think if you can link that with your diagnosis, I think those are good points that you can add. Also saying that you can notify the clinician of this diagnosis, because often the patients are unwell and you can start them promptly on some chemotherapy, and that they are often associated with an invariably poor prognosis.
Okay.
So the next case, we have a 50-year-old male with mediastinal lymph nodes, and this is again an EBUS case. So I can actually stay on this magnification because it's a reflection of the entire slide. So essentially what we have here, and then also in the background. And then just to assess the morphology of the nuclei and the quality of the cytoplasm. And then if I just take you to the PAP, where you have similar aggregates of these cells. Yes, and thank you for already giving me your diagnoses. So yes, you have correctly identified granulomatous inflammation. So I've shown these nice clusters of histiocytes forming granulomas, and they can be various sort of either epithelioid or more spindle shaped. So I showed an example where the nuclei are sort of kidney shaped and they're loosely aggregated on a background of lymphocytes. I think the important pertinent negative here to write in the exam is that there is no background necrosis, because then that guides your differential. So calling this non-necrotizing granulomatous inflammation is the correct answer. In terms of workup follow-up, you could say you can send off needle washings to microbiology, and in the absence of an infectious cause, the findings could be consistent with sarcoid if there's a clinical history or clinical suspicion. I think this case is also a good reminder to remember tumours that can often be seen in association with granulomatous inflammation. So my top 3 would be a Hodgkin's lymphoma. So when you see granulomas, have a look at the background, see if there are any RS or Hodgkin cells. The second one is a metastatic squamous cell carcinoma, because that often the keratin can induce a granulomatous inflammation. And in the mediastinal lymph nodes in a young patient, consider germ cell tumours. But I thought this was a good quick example of non-necrotizing granulomatous inflammation. So any questions?
So really, of course, the sort of key finding here is the confident recognition of the numerous cohesive, non-necrotizing epithelioid granulomata with a background population of mature and transformed reactive lymphoid population. There may be occasional giant cells, and then, as Maria mentioned, the absence of any necrosis and all of the other malignancies that you may want to exclude in this background. So yeah, spotting necrosis can be a bit of a challenge, I agree. Well, caseous necrosis is, very thick, amorphous, granular material, which is, a hallmark of TB. And if it is there in abundance, you will see it, you will recognize it. I don't think you need to be looking in a test situation for a focus of necrosis. I think if we're going to put out a case of TB, there will be, at least recognizable amounts of necrosis there for you to be able to find it. Remember, it's a test of interpretation, not a screening. So it's not about, 2 abnormal cells on a very cellular sample. It is about, looking at something in a matter of a few minutes and being able to come to a diagnosis or a differential diagnosis. So don't worry about, being able to spot focal necrosis. Okay, I think we'll come to our last case now.
Yes, of course. So this last case, so this is a 57-year-old female, and this is a unilateral pleural effusion, and the patient has a history of previous breast cancer. So I'll quickly show you the cytospins, and then we can use the last few minutes for the discussion of this case. And then I will bring you on to the PAP to show you the background cells. We can see these small mature lymphocytes and some histiocytes. And then I've put some pointers out onto some other cells which look distinctly different to our normal population. So these are reactive mesothelial cells. So does anyone want to give some, yes, thank you very much, positive for malignant cells? Do you think we can go any further on what type of malignancy this may be and why? So just reminding of the cytomorphology. Fantastic. Yes, great answers. Well done. Yeah, absolutely. So you've all correctly identified this as a malignant effusion, and you've gone further at subclassifying it as an adenocarcinoma for the features we've discussed previously, but essentially pleomorphic epithelial cells with intracytoplasmic maculations, eccentric irregular nuclei, coarse chromatin, and sometimes prominent nucleoli. So calling it an adenocarcinoma, you would then perform a cell block and immunohistochemistry. I think the important note to make of these sort of example is that you don't want to exhaust the material by doing a 20 immunopanel. And I think it's very important to be quite targeted and directed, because a lot of our material now is required for ancillary molecular testing. So in the case of a breast carcinoma, you'd want to be able to perform ER, PR, and HER2, because often these are required for oncologists to guide treatment. In the case of a lung adenocarcinoma, the oncologist wants to know the ALK, the ROS, the PD-L1, EGFR, and the RET mutation status before they're commenced on treatment. So important to confirm using limited immunohistochemistry panel. So for this, you could do a TTF1 or a GATA3, and then you've got material to do ER, PR, and HER2 given the clinical history. And obviously linking your answer to the clinical history. So given that she's got a breast carcinoma, this would probably be the first site of origin to exclude, and discussion at the MDM. So yeah, fantastic, well done. Any questions?
Well, Maria, thank you so much.
Thank you. I hope it was useful.
We'll find out from our attendees if they found it helpful, useful. I think it was. Thank you for putting together such a great selection of cases, very relevant, very much pitched right in, for a test situation, for a morphological interpretational session. And thank you everyone for attending, for participating, and being so interactive.
Yes, thank you for such an interactive crowd. It's so helpful as speakers to have such an engaging participant. So fantastic, and thank you all so much, and best of luck with what comes next.
Indeed, indeed. Thank you. Tony, is there anything else we need to say? I know there's a...
Sorry, go
on. I know there were some comments about access to the recording, but we can sort that out, I'm sure, fairly quickly for at least those people who have attended today and would like to view it again in a few weeks' time before the exam.
Yeah, I'm sure we can sort out a link that will go to those people that they can look at. Yeah, we'll be in touch.
Okay, well, have a great rest of the Saturday and the weekend, everyone.
Yeah,
all the best.
I'd just like to say quickly, anyway, just as chair of the BAC, just thanks all so much for coming. I mean, you've seen some really good real world examples there, I think, and excellent for those of you coming up to the exam, or indeed any exam. So the sort of sitting alongside Danijela and Maria was a great experience, actually, and really interactive. So thanks to all that. Thank you to those of you who are members who've attended. And if you have colleagues who are not members of the BAC, please consider nudging them to join. It's very cheap for trainees, and relatively cheap for trainees and biomedical scientists. So please consider pushing membership. We've got a new website, as you know. We'll be adding educational material to that as the months go on this year. So there will be stuff for you to look at. Those of you who are not BAC members, please consider joining. It would be great to have you on board. And also, you'll also be members of the European Federation of Cytology Societies, who, as you've seen, also have great meetings which you can attend. So, on behalf of the BAC, just thanks all for coming, and we look forward to seeing you at future meetings. Thanks a lot.